can hear as well. Hello. It's very exciting for me to be here, actually, because it's very rare for me to cross the river. And of course, I got lost. Anyway, but I will tell you now, those of you who are thinking of coming down south, there are more trees, and it is very attractive. And we have got jobs, SBRs at the back. Anyway, so, all right. So I'm going to talk about equality and diversity in medical education. And everyone here will at least teach medical students. And of course, some of you are trainees and will teach other trainees. And some of you are consultants and have trainees. And one of the issues that we have is that there is a differential attainment gap. Okay. First of all, I'm just going to give you a little bit of information. Hopefully you are aware of this. But the fact is that the machine doesn't want to work. That's number one. Let's try that now. Okay, there we are. All right. Your social situation in life determines your outcome in life. And we know that that's the case when it comes to our health. So this is just to remind you that where you are positioned on the hierarchy of the social scale will affect your exposure and your protection against certain diseases and disorders, etc. It'll affect your standard of living, you know, where you live, the kind of community you live in, and so on and so forth. Yeah. I always show this graph. Because I want people to understand about how ethnicity and deprivation interact. And this graph is just showing you on the left-hand side, you'll see that there are, look at the blue bars. At the bottom, this is a graph showing household wealth against ethnicity. And at the bottom of this graph is white British people who have on average about £300,000. It's not how much money you've got in the bank, it's how much your total wealth is, you know, including your house. And at the top of the graph, you have, with a lot less money, people from Black African groups, Bangladeshi groups, Chinese groups, okay? And why is that important? Well, it's important because number one, actually, if you're from a minoritized ethnic group in this country, you're more likely to be poorer. Number two, it's to show you this. You know, we've got a habit of lumping people together. So if you're from a South Asian background, it tends to be that you'll get lumped together. But if you look at this, the people who match white British people in terms of wealth are people who are South Asian of Indian origin. However, if you are South Asian of Bangladeshi origin, it's likely that you're going to be much poorer. And we see this in terms of health outcomes and other social outcomes. If you look at the graph on the right-hand side, this is looking at the groups who are in levels of deprivation. And the people who are most likely to be living in deprived areas are people from minoritized ethnic backgrounds, in particular, Pakistani people, Bangladeshi people. But again, if you look on the left-hand side, if you are South Asian of Indian origin, you'll actually be far less likely to be living in a deprived situation. Now, the question is why? What is the reason for that? The reason is historic. And we know that, say, for example, in the 1980s, 1 in 20 Indian men in this country was a doctor. Compare that to immigration in the 1980s of Bangladeshi people who were, for the most part, escaping flood, famine, and war. All right, so this isn't a talk about health outcomes, actually. This is a talk about education. So why am I telling you this? I'm telling you this because, funnily enough, despite all the kind of social factors about poverty and deprivation and how that might link with ethnicity, unusually, when it comes to being a doctor, the outcomes are not really dependent on your social background. They are dependent on your ethnicity. How well you do as a doctor depends on your ethnic background. That's what affects your outcome in medical training. Okay, so we've got to talk about this discrimination. And I always put these slides up because I'm always mindful that, especially now after the whole kind of George Floyd thing, etc., there's all this stuff about, I'm not going to talk to people about discrimination and racism, etc. You should just know it. Just go and read it yourself. Just go and find out for yourself what it is. I think that's a little bit harsh. And I think it's just better that everybody has the same understanding as far as possible. So we all know about this kind of discrimination. You know, when someone abuses someone because of their race or their gender or their ethnicity, or their religion, okay? And this is the example of Saka, who's feeling very pleased himself. I'm sure I understand that he scored goal recently. But remember when in the Euros and he missed the penalties and it was awful and everyone was very sad for him. But some people threw shouted monkey chants and threw bananas at him and stuff like that. And it was really horrible. And there was a big uproar and blah, blah, blah. That's just the example of overt, racism, obviously. And we all know what that is. And so when people say, that's racist behavior, being a bit racist, that's what we think. We think, this person is talking about that horrible nastiness that happens when you're really obviously overtly racist towards somebody. And we all know what that means. And there's good evidence now that it is associated with negative mental health outcomes, actually. I'm not going to go into that. But it's this type of discrimination that's perhaps a bit more important that we need to be understanding of and aware of. And that's institutional, structural, systemic discrimination, again, by race or gender or religion, etc. And what does it mean? It means when there's differential access to goods or services or even opportunities dependent on a person's protected characteristics, their race, their sex, their gender, etc. And it's manifest as a kind of inherited disadvantage. There's an expectation that because you are from a certain group, you will just be less good at something or less able at something, or that you won't be someone who's able to do certain things. And because there's an expectation of that, there's no real requirement to change that situation. So what I always do, I always think about women and, how the situation for women has so improved over time. If it was, I know, so people have heard me say this before, I'm going to say it again. If it was 150 years ago, the person giving this lecture at Barts, and I know Barts is old, so there would have been a person giving the lecture, but I suspect the walls wouldn't have been read. The person giving this lecture, Dr. Smith, would not have been a woman, for sure, because 150 years ago, it was well known that if women were educated to any kind of higher level at all, then our brains would boil and our ovaries would shrink. It's true, it was proven. Henry Maudsley, well-known notorious misogynist, said, this is a terrible thing to educate women. It's a horrendous thing. It's really bad for them. And in fact, there were scientific articles talking about how bad education was for women. And of course, if you were any caring, right-thinking parent, and little Angelica comes to you and said, Daddy, I want to be a doctor, you would say, darling Angelica, no, it's not for you. We can't have your brain boiling and we want grandchildren. No. You stick to needle points. So when Elizabeth Garrett Anderson wrote to medical schools and said, I want to be a doctor, they laughed. Ooh, what abomination against nature is this woman, thinking that she might actually be able to be a doctor? How dare she? What's she doing? Does she know what she's risking? So there would be people who were affronted, but there would also be people who just thought it was just a terrible, awful thing for women, and they wanted to protect women from this awful thing of education. And so after a while, people start to forget about what the reasons are. It's just known. So by the 1920s, it was just known that, well, women aren't doctors, are they? They're just not doctors. Women aren't doctors, and then even up to the 1950s. I met a very old doctor on Friday, actually, a woman called Helen, who was the widow of Ken Rawnsley, one of the very first presidents of Royal College of Psychiatrists. And she went to medical school in the 1950s and 60s. She went to the Middlesex. And she said that at that time, she had to work twice as hard as everybody else. People wondered what she was doing there. They laughed every time she opened her mouth in class, because most of the other people were male. And she was generally given the hardest, nastiest, dirtiest jobs. And when she was actually on the wards, her consultant would say to her, I keep forgetting that you're not one of the nurses. And really, it would have been a lot easier. Why don't you just stop this now and just become a nurse? You could become a senior nurse quite quickly, because you're going to get married anyway. So it was just assumed that she would not be good at what she did. There was an inherited disadvantage, and it was codified into our customs and our practices and our laws. And, she wasn't offered jobs, actually, because it was just assumed she wouldn't be able to do them. She wasn't offered career progression because it was assumed that she was going to go off and get married anyway. She wouldn't continue this. It was a waste of time. So there wasn't an active perpetrator. It's not that anyone was calling her names all the time and saying, calling her sexist names. It was literally that she just wasn't given the same opportunities that her male colleagues were. There was inaction in the face of need. Okay, so just to remind you about how sometimes the inaction in the face of need or policies that we put in place can inadvertently discriminate against whole groups of people. And these are just some examples. I always talk about the one baby policy, because I always think that one was one where, especially, it's very pertinent now. So you'll know that, in the early part of the 20th century, the Chinese were starving, actually. It was terrible. There were far too many Chinese people. They were starving, there wasn't enough food. This is before China became, the major powerhouse that it is now. The Chinese government said, everybody is starving, we cannot have this. What we're going to ask you all to do is only have one child, and that's for the good of you and the good of everybody else. And of course, everyone complied, because actually people didn't want to starve, but most people complied. But what the Chinese government kind of forgot about was that there was a general feeling that people thought, if I can only have one child, I need that child to be a male, because that male child is going to be able to look after me, look after the family, look after everyone else going forward. And so what ended up happening is that basically in mainland China, especially, if people had a female child, they would get rid of the female child. That child would get adopted away or gotten rid of some other way. So it's resulted in a situation whereby, and this is Amartya Sen works, if you want to look it up, there are approximately 50 million women missing from mainland China. So the women that you'd expect to be there, because you'd expect, 50-50 male to female when children are born, more or less, there are 50 million women missing, which means that in certain provinces, where if you're female, you're much more likely to get kidnapped by families who need to, reproduce, basically. And the Chinese government didn't plan this. It was just that inadvertently, that policy discriminated against women. And in fact, if you know someone who's adopted a child from China, that child will be invariably a female child. And then there's this. Okay, so this is internalized discrimination, all right? So this is just to show you, some of you will have heard of this, the doll experiment. This is Kenneth and Mamie Clark, the psychologists working in 1940s, 50s, segregated America. And what they did was to take two groups of children. These are kind of year one children, about 6 or 7 years of age. And they gave all there were a group of white children, a group of black children. They gave all the children two dolls, a white doll and a black doll. And they asked each of the children to rate these dolls. And they said, okay, which doll's a clever doll, the funny doll, the kind doll, the doll you want to, make friends with, the doll that's not going to get told off by the teacher, the doll that the teacher likes best and who's going to do best in life. Which doll's the bad doll, the naughty doll, the stupid doll, the doll that's going to get told off by the teacher, the doll that is, probably not going to do very well, okay? So when they asked this question, they had the white kids and they gave them both a doll. They said, which doll's the kind doll that you want to be friends with? Of course, all the white kids said the white doll. When they gave the dolls to the black kids and they said, okay, which doll's the kind doll, the funny doll, the one that you want to be friends with? The black kids also said the white doll. And what Kenneth and Mamie Clark said is this, that we all live in the same society. We all accept the negative stereotypes and assumptions about groups of people and their abilities and their intrinsic self-worth. And that gets imbued, imbibed, internalized into everybody. And what's interesting is it means that for whole groups of people, there is the self-devaluation. And you do see this. You see this, for example, in the West Indies and in India, where there's colorism and people are graded according to the darkness or fairness of their skin. So, you know, film stars are much more likely to have lighter skinned. A friend of mine who's a professor of psychiatry in Trinidad, he's about 60 odd now, he said that when he was 16 years of age, he went to work in a bank. He was the first dark-skinned black man to work in a bank in Trinidad. I didn't believe him. I said, no, that's got to be rubbish. And he said, no, it's true. People use bleaching creams to make their skin lighter. This is quite dangerous for them. And the problem is this, that self-devaluation can also result in people thinking, what's the point in me bothering? They drop out of school. What's the point in me voting? What's the point in me, you know, taking care of myself? More likely to engage in risky health behaviors. And on the left here is Jane Elliott. And she's a teacher in primary school again. She did a recent exit, this is much more recent. And she was trying to teach her kids about discrimination. And she said, right, the blue-eyed kids, what's going to happen is that you're not in charge anymore and you're not as good as the brown-eyed kids. And so from now on, the brown-eyed kids are in charge. By day 2, these blue-eyed kids who were confident, clever, the ones writing all the work, really putting their hands up in class, etc. By day 2, these kids were sitting on their own in the playground. They were shying away. They weren't getting involved in playing games with everybody else. They were getting upset. By day 3, the parents said, can you stop this experiment, please? Little Johnny, who was so confident and clever at the beginning of the week, is doing nothing now. It's horrendous. So it has an impact on people's self-esteem. Okay, so that's the basics. Anyway, so this is now, let's think about education. This is just a graph. This is from the Office of Students, actually, it's from 2021. And this is just to show you that it's one of those graphs. I have to say, I think considering it's from the Office of Students, it's a bit rubbish. It should be the other way around. But in fact, what it's showing is that the percentage or the numbers and percentage of children at 18 who go into education. Counterintuitively, the higher you are on the graph, the less likely you are to go into further education. And worryingly, this line here are the white kids, okay? White kids less likely to go into education for the proportion of white kids that there are. Down here, I think I'd call that lilac. I don't know what I'll call that color actually, kind of mint green, the yellow and the dark blue black lines. These are other mixed heritage kids, black kids and Asian kids who are much more likely to go into further education. Interesting. This is from Anton Emmanuel. And this is looking at who gets A levels and what happens to them in medicine. And you can see that at the 3 A grades at A level, this is good. You know, I know it's A stars now, but I think at that time, these are the ones who get 3 A grades. That's a top mark, the top you can get. You can see that Asian children match white kids, black kids, about half as well. These are the children who get into medical school. So these 18-year-olds get into medical school. When it comes to being accepted into medical school, then there's a difference. The differences start to become apparent. And then when you look at competence, people who are classed as being unsatisfactory, bearing in mind that, you know, they're all starting off with the same A levels, they're much more likely to be from a minoritized ethnic group, more likely to be an international medical graduate, way more likely to be an international medical graduate, and far less likely to be white. And then when it comes to postgraduate exams, there's again a significant difference. And when it comes to postgraduate exams, if you're white, much easier to pass your exams. However, if you are from a minoritized ethnic group, you're less likely to pass. And in particular, if you are from if you're basically trained overseas, from an overseas medical school, again, far less likely to pass. And the same thing goes all the way through to the point whereby when it comes to career progression, if you're from a minority ethnic group, you're just not going to do quite so well on average as a doctor. And remember, that's not to do with the fact that you might be from a poorer background, because this includes all those Indian doctors, Indian medical students who were the children of doctors, actually, who probably went to a very good grammar school and or a very highly selective private school, who are clever kids. This isn't, so it's not, I mean, this isn't just about the international medical graduates either, who you could argue, well, maybe it's a language thing, maybe it's a culture thing. No, these are people who have been brought up in Britain as well, who understand the mores of being a doctor because they've got medical parents often, and yet we still find that there are these discrepancies. All right, I'm going to say, it's like, oh, it's a bit annoying, but don't worry, there is guidance. There's guidance. And I would say to you, there's guidance from the GMC, there's guidance from the BMA. I think the BMA guidance is probably better, all right? And it's shorter, easy to read. But they do reference the GMC guidance though, and they say that, look, there are when we're talking about differential attainment, we're talking about systematic differences in outcomes when you group cohorts by their protected characteristics and socioeconomic background. But in practice, and all the research shows this is research showing this is not just me saying it, that the biggest gaps in attainment during medical training are to do with a person's racial background. And I've talked about the pass rates, and basically you're far less likely to pass if you are from a minority ethnic group. But even if you are white, if you are an international medical graduate, you are far less likely to pass your exams, your professional exams. All right, so Catherine Wolfe, she's an academic at UCL, and she's done a lot of work in this area. And I would urge you to have a look at some of her work if you're interested. And so people have said, what's the reason for people not doing so well, particularly these medical students and these doctors? And everyone says, well, it's probably because they're just not quite so clever. It's their academic, but oh, that's good, that's good. Someone laughed, but having said that, he is an international medical graduate. So people said it's the academic ability of the students and the doctors. Some people say, well, they've probably got poor exam techniques. It's like, well, that might work for the international medical graduates, but probably not, because they probably had to do more exams to get here in the first place. And some people say, and you know, it's just a bit dull. You know. Anyway, actually, it's not the individuals themselves. So when people say things like, you know, the thing is that the exams are fine, it's the people taking them that's got the problem. I don't think that's fair. And what Catherine Wolfe has found is that, in fact, it's something to do with our learning environment, and there is something about our exams. So for us as psychiatrists, you know, there are the written exams, and then there's the CASC exams. Now, there's this little bit of a difference when it comes to written exams, and we've got Ian here, he's chief examiner, so he can attest to that. Anyway, I was going to say Ian's done a lot of work on this actually, so things have really, really, really improved. But we do know that there is a bit of a difference when it comes to the written exams, but the big difference is at the CASC, and that's the clinical exam, that's the face-to-face exam. There's something about when you're seen, unfortunately, if you're from a minority ethnic group, you just thought not to be quite so good. So that kind of tells us it's probably not about academic ability. There's something, and also, I don't think it is about the individual either, actually. I mean, I'm pretty sure it's not about the individual. And especially when you see that when you look at the statistics about the differences between the CASC exam and then the written exam, it does look like there's something else going on. this, Catherine Will said, it's about learning environment. Our learning is a social activity. And I have to say, you guys at ELFT have got this absolutely off pat. I love the fact that everyone comes together and on a Wednesday afternoon and people go out and do what we used to do this. I remember we used to do this at the Moors, it was on a Friday afternoon, and everyone would have their teaching and then everyone would go and have a drink of tea and, you know, some cake, things like that. Anyway, but actually that, onto that point, actually, something about fitting in. In fact, actually, people would go to there's a pub called the Phoenix, and people go to the pub. Of course, if you're the kind of person who doesn't drink, then maybe going to the pub isn't really what you want to do, and maybe it would be better to have tea and cake occasionally. There's something about fitting in, because if you don't fit in, that affects how you relate to your peers and your seniors, yeah, and how, because you don't get to socialize with them outside of work, maybe. Something about how there's also something about trainers and giving feedback to people who don't look like you. And it's been found that you're less likely to get honest feedback about your performance if you're from a minority ethnic group. It's been questioned about whether there's bias in the work-based place assessments in recruitment. And then there's also something about low expectations, back to that kind of stereotypical assumptions that people have of certain groups. And then more recently, and this is going to become, I think, more of a problem with the change in training places across the country, there's something about lack of autonomy about where you're located and having poor life balance. And I think about someone I spoke to recently, and I have to say I recognise this. Someone I spoke to recently who is now a consultant of 4 or 5 years. She's from a South Asian background. She's an international medical graduate. She has 2 children. She just had a second child. She'd come back to work. She was on call. She was given an on-call shift that meant that basically she was on call really, really very quickly. She had a very young child. Her young child was sick, very sick, with a terrible high temperature. She didn't feel that she could call in to say, I can't come in because I'm really worried. My child is so unwell. I'm thinking about taking to hospital. Instead, what she did was to take her child on call with her. So the child was in the back of the car. She took her husband, who, you know, doesn't work in sales, took her husband, because the child wouldn't leave, you know, she didn't want to leave the child. The husband didn't know what to do because he's not doctor. In the back of the car, the husband sat there. She went and did the section, came back in between, then had to go following the ambulance. So she was there following the ambulance and the police to the hospital. Meanwhile, the child's in the back of the car, because she just felt that if she said anything, then it would count against her, and it would be a bad mark, and she wouldn't get her ARCP. And that kind of story is really common, I need to tell you, but people aren't going to tell you because they're going to feel like it shows some kind of sense of, you know, they're not so good, they're a bit weak, you know, etc. And she said, you know, I felt I had to work twice as hard to prove that I was just as good as my white colleagues. Anyway, but there is guidance. And when it comes to medical school training and medical students, again, the BMA have brought out this charter. I'm very pleased to say that Barts in London, well done, Ania, are signed up to this charter. The issues, I say children because they're 18 when they go in, Black students have said it's a bit difficult because there's an assumption that if you're a Black medical student, you're only there because of widening participation, that you've got in because because people have said you can get in because you're Black and you've got lower grades. So straight away, all that work you might have done, and bearing in mind that most people will have the same A levels because it's really hard to get to medical school, you know, they'd be taunted by some of their colleagues saying that you only got in because you got in under the widening participation things. It's a shame it's being used against them. But some of the tutors will separate the Black students from the other students. That people, this is just generally failing to pronounce names properly. It's not that hard. Just ask the person right at the beginning. We're really good. We're psychiatrists. We're good at building rapport with people. Just ask them what their name is right at the start and get them to, you know, get them to tell you it again and again until you get it in your head. And sometimes making overt racist remarks to students, which is not good. Anyway, what do you need to do? The charter is here now. You have to support the individuals to speak out. That means having a code of conduct, access to guidance and trained supporters, etc. Make sure there is a robust process for handling complaints And that means that, you have to review your existing reporting culture, procedures, and ensure that students know how to complain if they're worried. Do something like this, mainstream your EDI training into your environments. And that's actually what's happening right now. Well done, Helen, well done, Ania. It's got to be embedded throughout your curriculum. And also, if there is any racial harassment, and it'll usually be that someone's gone off to a placement in, Eastbourne or somewhere, and they've been racially abused during their placement, then you have to expect that placement will do something about it, so that the students can feel comfortable in reporting it, either anonymously, because they might not want to have to make a report about a particular patient, but they might want to say, just so you know, this happened. So you make sure that students know how to report if there's an issue. Okay, that's it. That's the problem. There are the answers. It's all there. This is me. I have to put that up because I've got to do some electioneering. People keep saying to me, do some electioneering. This is the electioneering. Okay. Anyway, thank you.
Thank you so much, Lade. A really important topic and really well presented. Thank you. And some rather frightening and upsetting examples there too, as I said. So, have we got time for one quick question? Ian, I'm thinking your chief examiner role. Can we let you comment?
Yeah. Oh, there's mics.
A microphone. Let me do some running. People online must want to.
Thank you, Lade. What's a great talk, and it's such an important topic, and definitely the best of luck in the presidential election. I just wanted to make, because you brought up a comment about the exam, and the MRC Psych exam is similar to these other postgraduate exams in terms of levels of differential attainment. And as you say, differential attainment gap is bigger in the clinical exams than in the written exams. We do a lot to make the exam as fair as possible. And actually, we have even a section on the website explaining what we do. But just to say a couple of things. So we've increased our reading time for the CAS in case English is not your first language. We've taken out the sort of more parochial aspects of stations. We set to an explicit blueprint. We standardize all examiners. We make sure our examiners and role players are a diverse bunch of people, reflecting the patient population and the medical population. And we train our examiners in unconscious bias. But despite doing all that, I still worry that there's bias in the exam. But I do think also, which you've said really, that a lot of differential attainment is due to much wider factors in terms of the training that people have experienced and that sort of thing. I think that the real take home for me, though, is the importance of social learning. And this is so important for the clinical exam. And I think as educators, that's one thing we can take away from this, is that we really try and facilitate these learning groups amongst candidates, and also having experienced examiners and experienced teachers helping to facilitate those practice groups, because they are absolutely essential to pass the exam. And I'd really encourage our educators to support those happening.
So thank you. And just to add to that, those of you who have successfully passed your exam, you will know that you need to have a study group. Just do, and people who don't have a study group are far less likely to pass. To have a study group, you have to have mates. If you're an international medical graduate come along, you're less likely to have them. So please reach out to your colleagues. Please encourage them to join your study group if you're at that stage. Thank you.
Okay, we probably need to move on. Thank you so much, Lade. Stefan, can I invite you to
Yes.
can I say a very warm, or not so warm in physical terms, but emotionally very warm welcome to Dr. Stefan van Gielen, who is from the Centre for Education at the University Medical Centre in Utrecht. Stefan's going to talk to us about challenge-based interdisciplinary learning in medical education. He has particular expertise in the medical humanities, and we're very much looking forward to a piece of exciting work going forward with the Utrecht team and a team in the United States, focusing on medical humanities and their role in medical education. So delighted to welcome you. I'm sorry it's so cold.
Perhaps someone can help with getting the right presentation.
Just straight. So it should be.
Yes. Okay, so it's an honor to be here. Thank you very much for inviting me. And also thank you very much for adjusting the temperatures to our Dutch climate. I feel at home at once. So let me start off with two apologies. The first is, I am a philosopher, and it feels a bit strange to stand here to talk to you about medical education. So my second apology is English is not my first language, nor is it my second language. So please bear with me. As you can see, I also changed the title of my presentation somewhat because I also wanted to speak to you about not only what we are doing in medical education in Utrecht, but also to give you an idea of the broader context in which we are working, and that broader context is the new Utrecht School. So this is an outline of my presentation. First, I will tell you a little bit about the new Utrecht School. Then I will briefly go into some of the historical roots of the new Utrecht School. And then I'm going to talk about how we are trying to implement an interdisciplinary paradigm in medical education. And hopefully we have time for some questions and dialogue. So the new Utrecht School. The new Utrecht School was founded in 2017 as an interdisciplinary and interinstitutional platform of Utrecht University, the Applied University of the Arts Utrecht, and the University Medical Center Utrecht for interdisciplinary cooperation in the broadly defined health domain. And when I say broadly defined, I truly mean broadly defined, as broadly as possible. So we look at topics on public health, global health, on topics of One Health, the relation between the well-being of animals and human health, on planetary health, and we focus on healthcare. So this afternoon is about medical education in the post-COVID era. And I think when we ask ourselves the questions, why should we have more interdisciplinary collaboration in the health domain? I think that COVID is a clear example of that. Of course, our first reactions to the COVID pandemic were to study the virus from a biomedical perspective, to focus on epidemiology, on virology and vaccination. But I think it also soon became clear that we can only have effective interventions if we also take it serious that our health is not our individual health, it's the health of all of us. So we have to focus on health behavior as well. We have to focus on how we communicate about interventions in the health domain. We have to discuss how our own health is related to the well-being of animals. And we truly need to address the decreasing public trust in science. I'm not sure whether you have it here in the UK as well, but I imagine you do. We have a lot of anti-vaxxers, a lot of fake news. So these are topics that we need to address. And also we need to look at the legal foundations of large-scale health interventions. And we need to truly think about the mental, the social, and the economic consequences of the interventions from COVID. So I think COVID is a good example for why we need this interdisciplinary collaboration. So a little bit about the institutions that I just mentioned. Utrecht University is one of the largest universities in the Netherlands. We have 6,000 employees, 30,000 students. The university is divided in 7 faculties and 2 university colleges. The Applied University of the Arts Utrecht was established in 1875, starting with the Conservatory of Music. It's the largest applied university of the arts in the Netherlands. It has 4,400 students divided over 9 schools. And the University Medical Center, Utrecht, was established in 1871. I know that's quite a bit later than the London Hospital Medical College, but nonetheless, we have 1,000 beds, 12,000 employees divided over 10 divisions, and we are also the Faculty of Medicine. So the new Utrecht School. Like I said, we started in 2017, but already in 2020, the new Utrecht School was adopted as one of the 7 focus areas of the University Medical Center Utrecht. And also in the long-term strategic plans of Utrecht University. What do we focus on in the new Utrecht School? We focus on interdisciplinary education and training, educational innovation, and educational research in the health domain. And we focus especially on interprofessional learning, interdisciplinary education, patient participation, diversity and inclusion. We have the same problems, probably a lot bigger even than you have here. We also have problems in making people interested in this topic. I find that when you speak to medical specialists, that it's also important to note that inclusion and diversion is also about how we look at disease, that the symptoms of disease are not the same in men as they are in females, that often the way in which we design our research depends on what kind of patient populations we address. Much of our research is based on evidence found in Northwest European white men. But it goes even deeper. It's also in the animal models that we use. We usually don't know whether they are male or female, and in the cell lines we use. And then we also focus on student well-being and the continuum of the learning and working environment, because we have really a big problem. We are trying to educate creative problem solvers and critical thinkers. But when they start doing their residencies and they go to the workplace, those are not at all the skills or the attitudes that are wanted there or are encouraged. So this is a great problem for us. Then, just to show you a couple of our educational innovations. This year we started a bachelor program, Care, Health and Society. It's a collaboration between the Faculty of Medicine, the Faculty of Veterinary Medicine, and the Faculty of Sciences. It's a 3-year bachelor program. And when students have completed this program, they are able to start medical school, the medical master's program, the master's in veterinary medicine, and the master in pharmacy. This year we also started, as Helen indicated, an interdisciplinary Master of Science program in the medical humanities, which is a collaboration between the Faculty of Medicine and the Faculty of the Humanities. We have now a group of students with half have a background in medicine and the other half have a background in the humanities. We are working in a European university, CHARM, together with 5 universities. And like you already mentioned, we are also looking into new courses as an internationalization at home, together with the NHS East London, with QMAL, with Drew University in the States, and with Utrecht. So a little bit about the historical Utrecht School, and this is just because we're proud that we have historical roots. I do realize that these are old white men, mostly. But like you already said, this was just the way it was not too long ago. Nonetheless, I think this was a really interesting group of people. They were psychiatrists, psychologists. They came from pedagogy, from law, from forensic psychiatry and medicine, biology. And they found each other in shared principles. And those were that they focused on understanding individuals from within the complexity of their personal and social world. They truly collaborated interdisciplinary, and they were convinced that science is most effective when it is conducted in interdisciplinary collaboration. And they also made it a point that science should truly benefit broader society. To give you an idea, and I know most of you are psychiatrists, so I have here two quotes by two famous psychiatrists from the Utrecht School. I hope you allow me to read them. Rümke was the rector of Utrecht University, and he was the head of the academic psychiatric clinic in Utrecht. And he said, if one were to ask me what the most defining characteristic of psychiatry is, both as a part of practical medicine and as a science, my answer would be this: that psychiatry, through its object of study, belongs neither exclusively to the natural sciences nor exclusively to the humanities. Van den Berg was also a psychiatrist. He was also head of the psychiatric university clinic. And he stated, humans are presently studied as objects, but humans are not things. Man is a dialogue. He is the continuous self-evident communication with himself, with others, and with phenomena, the latter of which also, in a very specific way, but no less immediately, speak to him. Now, what does all of this have to do with medical education? I think we all know and see that healthcare is rapidly changing. There are huge challenges confronting the healthcare and the health domain. And that means that we truly need to think about the future of medical education and how we should reform medical education in a way that we are able to address these challenges. And I think these challenges can be found at least on 3 levels. So I think there are societal challenges, there are challenges on a clinical and a professional level, and there are challenges on the level of fundamental science. I want to give you a couple of examples of these. I hope you all know these examples, so I'll go through them quickly, but I've also addressed audiences to whom these challenges were new. So. Probably you all know this urgent call made by the editors of 200 medical journals just recently in the New England Journal of Medicine, in which they identified global changes in temperature as one of the main risks for human health. But of course, and this you do know, is there's a worldwide crisis in mental health. This Lancet article is from 2011. It speaks about the crisis in the mental health of children and adolescents. And in the past years, this crisis did not get any better. Actually, it got worse, and there's lots of evidence for that as well. This is a global mental health challenge. But we should think about what we're doing with these challenges in our medical education. On a professional level, in Utrecht, we were very much inspired by this article, or actually an editorial in the New England Journal of Medicine in 2016. Was called Tolerating Uncertainty, the Next Medical Revolution. And in it, the authors argue that when we become obsessed with finding the right answer, at the risk of oversimplifying the richly iterative and evolutionary nature of clinical reasoning, the result is the very antithesis of humanistic, individualized, patient-centered care. So I think it's important when we think about medical education that we think about, okay, why are we constantly striving for perfection and solutions, and Why are we not teaching our students and perhaps even ourselves how we should deal with uncertainty? I think that this is one of the places where we think that it's so important to collaborate with the arts, because we believe that the arts are a place where you are able to experiment with uncertainty without it having true life consequences. And I spoke a bit about the mental health crisis in children and adolescents, but of course this is also a problem in your profession. There's a true mental health crisis. There's a burnout crisis among medical students, among residents, among medical specialists. And if you think, oh, well, but this is the Journal of the American Medical Association, this is an American problem. I do not think so. I mean, we have the exact same problem in the Netherlands, and hopefully you don't in the UK, but I'm seeing a lot of recognition when I look around me. So these are things that we really need to consider. These are challenges, and we need to do something with it in our medical education. And then my last challenge, you probably remember this discussion in the Lancet in 2014 already. How many people know this article? Okay. So then I'll address it a bit. The article is called "Increasing Value, Reducing Waste." It's part of a 5-article series in the Lancet. It is about the immense funding for biomedical research, which never finds its way to clinical practice or healthcare. So there are we spend so much money on doing fundamental biomedical research, and most of it is lost for healthcare. No patients get better from this research. So we really need to think about how are we going to address this valley of death, as it is called, between biomedical science and clinical practice. So we need to think about new ways of doing translational medicine. How can we move from bench to bedside to society? So before I want to talk to you about how we are trying to deal with these challenges in Utrecht. I think it's good to say a little bit about the way medical education is designed in the Netherlands. So usually we have a bachelor program, a 3-year program, in which students are primarily trained in theoretical knowledge and skills. After that, they go on to a master's program, also a 3-year program, which is mainly focused on practical residencies. And after that, if they want, they have the opportunity to do specialist training, which usually takes 4 years. In Utrecht, we do it a little bit different. We start with our internships in the last year of the bachelor already. And we also have a selective Utrecht medical master, which is a 4-year training as clinician scientists. So these are students with a non-medical background who start to do a master in medicine. And then this problem, I mean, I think it will be very recognizable for most of you. You want to do all these things and you want to address all these challenges in your education. But of course, the curriculum is already full. There is no room for any additional content, be that interdisciplinary or not. So how should we deal with this? So this is the way we are trying to do it in Utrecht. So we're saying interdisciplinarity is not something which is just content. It's not something which you teach, but it's also something which you can teach through the form in which you do it. So on a scientific level, we have students in medicine cooperating closely with students in biomedical sciences on shared challenges. We have a BIT training, which I'll talk about a bit more in the next slide. On a clinical levels, our students are trained to work together with patients structurally throughout the curriculum. We do interprofessional learning. So this is our medical students work together with nursing students and paramedics. And on a societal level, our students work together with students in the humanities on societal challenges. And we also do community engaged learning, for example, residencies in local communities. So a bit more, this is what we're doing on the level of fundamental science. We have the Bachelor Research Hub. Just 2 weeks ago, we had a large challenge in which 400 bachelor students from medicine and biomedical sciences started working on the challenge of long COVID, and they were studying ways and writing proposal to study the autoimmune response in long COVID. And the result of that is that the best proposals in the next courses get to work on this problem. We also have the Biomedtech Nutrition Interdisciplinary Team Training. That's a mouthful. But here, students work together with students of technical universities and with universities focused on lifestyle and prevention. For example, here they have been working in their latest challenge. They were working on new ways to study brain development in prematurely born babies. In clinical practice or on the bedside level, we do a lot of patient participation. Not only do medical students work together with patients throughout the curriculum, we also have a module in which they have to live as if they are patients themselves for 2 weeks. So they sign their own treatment, simulated treatment. They discuss this with patients. They live as if they were patients for 2 weeks, and then they present their results to the patients. We did research on this, and it's a really simple intervention, but it significantly increases students' insight into the patient's perspectives. We are also working on establishing a patient-centered educational agenda along the lines of the James Lind Alliance. So we're really trying to question our patients, what they want to see that is represented in our medical education. I said a little bit about interprofessional learning. Importantly, we are trying not only to do this on the bachelor level and in the master level, but we're trying to do it continually into specialist training as well. And finally, on a societal level, like I said, we are working together between the Faculty of Medicine and the Faculty of the Humanities on societal challenges, and we do community engaged learning. This was my presentation because I wanted to have some room for questions and dialogue. This is a book which we are presenting tomorrow. I'm proud of it. I'm sorry, it's in Dutch. But it has contributions by the board of directors of the university and the board of directors of our medical center and of the Applied University of the Arts, and all the deans of all the faculties of the university also have contributions. So I think this really gives us, we are just getting started, but this is really going to help us in really coming together and starting a dialogue from a really huge perspective, diversity of perspectives. Some references, if you want to read a bit more about what we are doing. And then thank you for your time and your attention.
Thanks very much, Stefan. That was a very interesting presentation, and both reassuring and challenging to hear that you're facing exactly the same challenges that we are, and thinking very constructively about how we can move forward in the post-COVID era to address some of them and produce medical students, doctors, forward into careers who are able to cope with a very challenging environment with flexibility and all those sorts of things, resilience that are really challenging to teach and develop.
And if I may say, not only students, but also the lifelong learners, of course,
Absolutely.
because we are all students.
I think we've got time for just a couple of quick questions. Does anybody have a question?
Thank you. That was really interesting. Thank you. How do students live as patients for 2 weeks? You said students simulate being patients. I'd love to know what that involves.
Yeah, so, first we started off in just saying, okay, now you are a patient with cystic fibrosis. So you have to inhale and you have to take placebo and you have to take 10,000 steps every day, and you have to do social segregation. So if you meet one of your fellow students, you can't be in the same room with them. It worked, but we wanted to optimize it. So now the students themselves are deciding what type of regimen they want to follow. So they're discussing it with patients, and everyone knows someone who has an illness or a disease, and some people are even trying to simulate being a psychiatric patient. So they're waking themselves up every night to see if they can simulate sleep deprivation. They turn their teams off for 30 seconds to simulate the concentration problems in ADHD, for example. That's the way. It's really easy, but it's just another form of simulation education. Normally in simulation education, you simulate your own future tasks and responsibilities. But we are saying, yeah, but what you can also do is simulating being the other person in the patient caregiver interaction. I saw a question there as well.
It's interesting in this connection between medicine and the humanities. Can you elaborate a little bit on that one?
Yeah.
You know.
Sorry.
So I think communication in healthcare is key, for example, and why not talk about communication in healthcare with those people who are most specialized in communication scientists. I mean, I've been here before in this room. There was a discussion on medically unexplained physical symptoms, which are now called bodily distress disorders. The problem is that there are no true physical or mental causes found for these disorders, so that you also have a philosophical problem about how you define psychiatric disorder or psychosomatic disorders. There are many ethical questions about how long you want to prolong your treatment, or who do you want to give the most expensive treatments. So you can discuss these things with ethicists. We are doing a lot in narrative medicine. So narrative medicine is the notion that you can gain a lot of insight into the perspective of other patients by reading literature or trying to analyze their stories as if they were literature. So that there are many things. And so we have a minor, which is 4 courses. It's one on hospital communication. It's one about philosophy and history of medicine. It's one on narrative medicine, and it's one on AI and big data in healthcare. And we take these subjects and we work on those in the master's program as well. And what I want to say is, in this master's program, medical humanities, we have a lot of medical students who decide after their 3 years in the bachelor that they're thinking, okay, do I really want to continue this path that I've chosen when I was 18? And so they start, and they do a 1-year program in medical humanities. And some of them go back and start their masters in medicine, and some don't.
Thank you.
Thank you very much, Stefan. I know Stefan's going to be around for the first bit of the break, so I'm sure he's happy to take further questions because it's a really fascinating area. So thank you very much.
Thank you very much.
Right, I hope I've finally taken my coat off. I think we've now got some heat, haven't we? So that's a great improvement. Right, for our next speaker, it gives me huge pleasure to welcome Professor Subo Dave. I'm sure Subo doesn't need much introduction to nearly all of us, but as you know, he's the Dean of the Royal College of Psychiatrists. And ever since I've known Subo, he's always cared passionately about quality of medical education, delivering medical education, all the things we've already talked about, like differential attainment. And I can't think of anybody better to talk to us about the future of psychiatric education. So thank you, Subo. We're delighted to have you with us.
Thank you so much. Am I audible in the back? Yep. Okay, that's great. Well, thank you for inviting me here. And I think thank you for all that you've been doing. I know it's been a difficult few years, and I think looks like it's winter of discontent. So everything that people are doing, I'm really grateful for all they're doing for our patients, and especially to medical educators, because keeping the workforce going is not sexy sometimes, not thought of as being sexy, but it's absolutely vital. And so to me, I think it's absolutely integral to our role as clinicians that we actually get involved in training the future workforce. So a very important topic today. A lot of what I'm going to say is covered in my update. So if you want to look up on anything or want to get involved in any of the streams of work that are happening at the college, please just Google Dean's annual update, and you'll find the program of action that we're involved in. There are several work streams, and more than welcome to participate. We're always looking for people keen to get involved. So there are lots of issues today that I'm going to touch on a few key elements, but I think if I had to distill them down to two things, and Stefan, it kind of relates to a lot to the points that you've already made. So the first thing I think is that not just psychiatric education, but medical education as well. I think from the time of Flexner, when the first medical schools were set up in 1910, so it's over a century ago, the formula hasn't really changed much, has it? It's 2 clinical years, then clinical years. The model is very much that, well, you look at, what's wrong with your liver, let me understand how to palpate the liver, let me figure out how to scan the liver, let me find the pathology in the liver, and then let me try and treat it. And I think that's the kind of model of clinical reasoning that we continue to follow. And I think so we generally see ourselves as interventionists, and I think the idea that we should also be preventionists doesn't enter our mind. And I think that is true probably for most of us as well. I mean, I'm not pointing fingers at anyone. I think most of us, do I know what the dose of risperidone, what's the dose of clozapine, how to safely prescribe clozapine? Now, whether the patient has actually taken clozapine, whether there are other factors in their life that stop them from taking clozapine, etc., is then left to the system. And whose job is it to influence the system? Whose job is it to kind of make sure that the scientific treatment that we have advised and prescribed is actually taking effect? And then, so for me, I think that moving from the idea of seeing ourselves as being responsible for the care of our individual patient to also think of ourselves being responsible for the care of the communities that we practice in is a critical step. Now, Stefan, you touched upon it. I think that is something that is not embedded in medical practice. I think our article appeared in the BMJ Social Innovation Special article. So I haven't got a reference on here, but I'm happy to share that later, which kind of discusses that in detail. So that's one key thing. And I think when you look at good medical practice or even our good psychiatric practice, you can see that the phrase community doesn't appear at all. It's all about, so our professional attributes are very much tied to how do you relate to an individual patient. And I think we need to, as a body of doctors and medical educators, see whether we want to change that. And certainly I think we have an opportunity in our college to look at a good psychiatric practice. And I think certainly we'll be looking at that and seeing what do we think of ourselves in relation to our communities, not just our individual patients. The second thing I think, and which is linked as well, and I think perhaps particularly relevant to the UK, where the notion of protected teaching time, a very noble initiative, I would say, has kind of been translated in creating two parallel worlds. And I'm aware that this may be a bit controversial to say in a room full of educators, but I feel that I've seen that in the clinical world, the clinical directors, medical directors, and TPDs, or that's training program directors, and other kind of schools of psychiatry, etc., often assume a slightly adversarial position. So educators trying to guard their turf and clinical educator and medical directors being kind of busy with the world of delivering real care and not being really interested in actual medical education, not thinking that this needs to be protected in your clinical time. And I think this is really a false dichotomy. We do need protected teaching time, but we need it in the workspace. How do you teach in a busy ward round? How do you teach in a busy outpatients clinic? How do you actually teach in the community? Now, that's the kind of question that medical directors are interested in, right? They're all thinking, well, how do you engage with communities? How do you engage with the voluntary sector? But they're not really involved in the education communities. I think this is a second key issue. So with these two big issues in mind, I think I'll kind of talk about these 5 key challenges that I see them. And I'll touch upon some of the things that we as a college are doing to address them. So health inequalities, I mean, what better way to test how good your educational training offer is than to see how well it performs against the most vulnerable sections of the population, right? And we should be checking that, right? We should be seeing that, well, if our education and training is delivering what it should do, that is good outcomes for patients, then it should be delivering consistently against the weakest link. And I think that we probably haven't done that always. We haven't really tested our education and training offer against this mark. And I think, I don't know in this room, how many of you know of Marmot or have heard of him? I asked that question in every room. I won't embarrass this audience. It's easier to do that perhaps online. But many of our medical students have not. Many of our trainees have not. And I think we need to address that. And Stefan, you raised the point all about the translation research. And I think the same thing, I think the robustness of the literature around social determinants is incredible, you know, especially in the last 2 decades. There's so much of scientific evidence base that is built in, and it's not yet translated into a practice at all. Now, if any of us didn't prescribe clozapine safely, that would be a matter perhaps worth referring to the GMC, right? Certainly a disciplinary matter internally. And yet ignoring social evidence that are robust and well proven, and we all go about our daily lives as if it's not an issue at all. I mean, let's look at some of the big findings, right? I mean, we've all known about poor housing and psychosis, right? I was taught as a medical student. So this is finding 40 years old. And again, I'm not pointing fingers at anyone because I've done this myself. As an inpatient consultant, I have discharged my patients into poor housing, into a hostel in inner city Derby, where I know that they would relapse. How do we allow that to happen? How do we allow a system where that is allowed to coexist with a world where prescribing errors are taboo? And I think that's something we probably haven't challenged enough as medical educators. And I guess that's my challenge to all of us. And look at this data. I mean, the slide looks old because it is old. It's 25 years old. So this finding is not new, right? And all of us have seen Leicester tools and so many different things appear, and yet we haven't really dented this. And I think that blame, that burden of actually addressing this lies as much on educators as on clinical service providers. And I think we need to kind of think about, well, what are the changes that we need to make into our education and training offer? And again, I'm with Stefan. This is not just about trainees. It's not just about people who are doing their core psychiatry or higher specialist training. This is about the workforce as a whole. How do we actually translate this? We are specialists in education. We should be using our educational expertise to actually translate that into real clinical behavior. And I guess there are tools available. I think we need to be doing that. The science around adverse childhood experiences is built up. We know that if you have 4 ACEs or more, it's linked with a number of adverse health outcomes. You know, and again, I say this as an adult psychiatrist. Did I do enough to look into the adverse childhood experiences that a lot of my patients' children or their young dependents were experiencing? What did I do as an adult psychiatrist? What are adult trainees? I know how many adult trainees here, adult psychiatric trainees? How many of you are actually learning about this in your curriculum? I think CAMS does it quite well. I think the training in ACEs, even in the UK right now, across the country, is patchy. Obviously, as a dean, I intend to fix it, but I think this is something that the science has been around for at least a decade now. And we haven't, it's there in our curriculum, but I don't think that it's translated into everyday practice. And I think we need to do that. I mean, developmental psychiatry is not just for CAMS and ID, it is for all of us. And I think I say that as a liaison psychiatrist who sees this routinely being played out in so many of my older patients as well. So it's relevant for you as well if you're an old age psychiatric trainee. I think And quite often, I think inequalities is kind of narrowly translated as something around just ethnicity or gender inequalities. And I just putting up this slide that yes, of course, this is true as well. And these figures are shocking. And Nadia, you probably might have touched upon these already, so I won't spend any more time on this slide. But, and so I won't go into all the other inequalities. But again, I think it is absolutely vital that we as clinicians know about these inequalities, know what causes inequalities, know what perpetuates inequalities, and know what is our role in addressing those inequalities. I don't think that it's an optional extra. And which is why, as a college, I feel that for us, the challenge is not to kind of see this as an optional extra that is available as a course that a few of our trainees will go on a leadership course or an inequalities course. This is something that has to be embedded and woven into our core training and our higher specialist training. And COVID has really shown a spotlight on how this idea that that inequalities is only for a few is a myth. I think a lot of these are all. I've got some colleagues in this slide. These are our colleagues who sadly were victims of COVID during COVID, and we know that a majority of them were from BAME backgrounds or international doctors. And I don't think we can ignore this finding because it's not us and them anymore. I think, and that idea, I think, is actually very prevalent. I think I've got a slide later on, but that shows a graph where we see that the idea is that the more polarized a society is, the worse are the health outcomes on a whole range of measures. And yet I think somehow we all have this belief that if you are at the receiving end of disadvantage, the inequalities will only affect if you are at the receiving end of the disadvantage. It doesn't affect all of us. I think it's actually not true. It affects all of us. If you're a millionaire living in Kensington, your outcomes may be slightly better than a millionaire living in this part as you start moving eastwards towards the college. But you're still going to be worse off than a millionaire living in Finland. And I think that's something that we forget. And that's what happened with COVID, right? One of the richest nations in the world ends up having a very, very sad statistic, both in terms of staff mortality and in terms of patient mortality. So I think something to bear in mind that it actually does affect all of us. And I think I've seen this personally. I think, Helen, you mentioned differential attainment. When I took that on as associate dean, I looked up the publicly available school minutes of every school of psychiatry in the country. Now, bearing in mind that the pass rate for international medical graduates was around 40%, pass rate for UK white graduates was around 85%, UK Black and ethnic minority graduates was around 70%. So we've seen these differences, and yet not one school had this item as a standing item on their agenda. I think the idea that, well, when I started organizing conferences to address this in the first couple of years, only IMGs turned up to these conferences as if it was something that was an issue only for IMGs. And I think that's the kind of thing that happens when you discuss inequalities. Somehow we feel that this is really for the poor, this is really for those who are living in social housing, this is really for people who went to comprehensive school, et cetera, et cetera. It affects health outcomes for all of us. And no better slide than this to talk about sustainability. Our college is a leader in sustainability, and rightly so, because we can't pretend that we are disconnected from the rest of the world. This is really a connected world. And so the links I talked about. And that was a slide I was saying, let you have a look at the slide. Kind of shows the graph that, that of course, US is US is way up there as a polarized nation. But UK doesn't do very well either, given how rich a nation we are. Our health outcomes don't compare very well. And I think that's a question that we need to ask. And to translate this into medical education, what does this mean for us as medical educators? And so what the approach that we've taken as a college is that we've got our new curricula. I don't know whether you touched upon this. You did some of this work with Raj as a presidential lead, contributing to the development of the curriculum. But we've got two big lenses. And one is very much around the person-centered care, the personalized care. And then this is important because we want to train clinicians who are not robots, right? I mean, we don't want you to blindly apply nice guidelines to every patient who walks through the door. We want you to know when do you not apply those guidelines, when do you switch away from the guidelines, and then why are you doing that? We want you to know all of that. We want you to know that, the formulation skills, we want you to have those formulation skills so that you can take into account the person's background, their socioeconomic background, their cultural background, et cetera, et cetera. And the second lens is that public mental health. So we want you to not just be aware of the case-based discussion that you have, but also the case load-based discussion. What does it mean to actually have a person in your caseload who hasn't done very well on a particular outcome, let's say on alcohol withdrawal when they got admitted, what does that mean for your overall practice? If you have one person who's a frequent attender, attending ED 25 times in the last 2 weeks, what does that say about the other frequenters? Do you know who the illness patients in your catchment area are? I'm not sure whether that is kind of prevalent practice, and I'm not sure whether we as educators see our job to educate our trainees and our workforce in this data. So we put all this in the curriculum, and I think this was hard enough. So I'm not trying to minimize this achievement because it takes years to actually devise this and actually to overcome all the barriers and in putting something fairly straightforward, such as these learning outcomes in the curricula. And then so we've got some very good learning outcomes, and I'm not sure how many of you have seen the new curricula, but if you haven't, please do have a look at them. The higher level outcome, we've got 9 higher level outcomes, and then one of them is very much around the whole idea of addressing health inequalities, about thinking of our role as preventionists, not just as interventionists. And then we got some very discrete learning outcomes. So I won't go into each of them, but it goes into details around, being aware of protected characteristics, being aware of the factors contributing to health inequalities, et cetera, et cetera. But now comes the difficult job of translating all this into action. I mean, I don't know how many of you actually are curriculum geeks and then actually go and read the curricula, but how do you translate this in your daily practice? I guess this is a real challenge. And so we've now got, we've appointed a fellow, and what should happen over the next year is that we will be doing a gap analysis of all the MRSI courses across the country to see what is actually happening at the ground level in terms of learning. What are the trainees learning? We've said what they are meant to learn. Now, what's the gap and how do we address that gap? So that's going to be one level work. We've appointed our fellow and our supervisor for that. We got a grant from Health Education England to do that. I've also set up an expert reference group, which I will be co-chairing with Cambui. Cambui, an ex-alumnus of QMUL, of course. Oxford has poached him from you, but very, very wise soul. And we have 3 simple tasks. I say simple. The first one, I think, is a challenging one. Again, I think I have some form in this. I think some of you may have read the college report on person-centered care in training and education. And when I founded that scoping group and I chaired that group with Jed Boardman, again, Jed Boardman may be familiar to some of you in the audience, it was to actually, again, devise a common vocabulary to address the issue, the same conceptual space. We were all discussing the same conceptual space, but we were using different phrases: compassionate care, intelligent kindness, human rights, recovery model, rehab, and person-centered care. So we tried to bring it all into an umbrella of person-centered care. And I think I want to do something similar, because when you look at the literature, the American literature talks about social determinants, it talks about race disparities. In this country, we talk about inequalities, sometimes inequity, and NHS talks one language, Health Education England talks another language. And both in terms of education and research, the language is very disparate. I think we need to try and bring some degree of commonality in the vocabulary in terms of our educational training offers, at least. And then I think the question of what is best practice in training related to addressing health inequalities. And we've got some ideas, some great ideas, Stefan, from you in terms of community engagement. I love the idea of actual residencies in the community. I think I really feel that providers getting employers invested in their trainees is a win-win. Employers, for them, I'm talking about that in a second, workforce is their #1 issue. They are battling chronic vacancies in the workforce, and yet they are so far removed from being invested in training. And I think one way of getting them involved is by getting them to create those training opportunities in the actual communities. And again, models exist. I've been sending my medical students to local day centers for the last few years, and it works really well. Students love that. Feedback from them is amazing. Patients love that. And the voluntary sector loves it too. And I think all of that is possible and feasible. So it's not rocket science, but I think we need to identify those best practices and then bring them under one umbrella. And then I think Ian Hall's here, our chief examiner. Assessment drives learning, we know that. And so what is best practice? How do we know that our trainees have actually learned all these things? If it is so important that we put it in the curriculum, if it is so important that we feel we want to make sure all our trainees learn this, then we need to quality assure that. So making training relevant to population needs, I think this slide kind of captures it all. I don't know whether all of you agree. How many of you are community psychiatrists here? I was one for many, many years, and I would have said maybe not 5%, 15%. But 15% of my population was pure mental illness. The rest all had comorbidities, right? And then that must be true for all of us, right? Irrespective of where you're practicing, our patients don't come purely with mental illness. Yet our training programs are designed as if our patients and as our medical work, as our workforce, should only be able to do one thing. And I think we need to kind of respond to what is the real need at the ground level and respond to this slide. That a lot of our patients, a third of our patients have substance misuse comorbidities. Almost 2/3 of our patients have physical comorbidities. And I think we need to, I mean, given the fact that there's such a large mortality gap, we need to be asking, is it heretical to ask that our trainees know how to, prescribe antibiotics, anti-diabetic medication? I think all of these are, reasonable questions to ask, and I think at least see what happens. I think there are many parts of the world where psychiatrists are treating epilepsy, they're treating infections, they're treating whole lots of things. I think what should be our role? I don't think there's even a conversation happening. I think as educators, we should be a part of the conversation. We should be driving that conversation. I'm not saying that we'll end up one way or the other. And, but I think that lack of that conversation is a bit worrying. I think we need to have that conversation. Clearly, aging population is a big issue. And so as a college, I feel that making our training meaningful and then ready for the changes that are happening in our demographic is absolutely critical. So one of the first things I've started doing is actually mapping existing resources, because we've got a huge amount of resource available, educational resource. And if we're thinking of upskilling our workforce, I don't think we need to reinvent the wheel in terms of redesigning lots of resources. I think we already have a lot. So we started doing that. But some things we need to kind of create a whole new impetus to drive the upskilling of the workforce. And eating disorder is such an example. Helen, you've done a splendid job as the Associate Dean for credentialing, leading that eating disorder, creating that in record time. It's amazing what you've done, really. And we had 270 applicants for 30 places. And so, in a sense, we created a resource, what Helen and her team have done, which essentially can upskill a large segment of the workforce to try and address clinical need. And I think that's the space I see ourselves as we should be in, as medical educators, as a Royal College of Psychiatrists. But how can we actually help solve the problems of our patient need, what our patients need? So we're working on international diploma. We are an international college. Almost 20% of our membership is international. So the kind of problems I've talked about in the UK setting, they exist in other parts of the world as well. We have a lot of members in Africa. We have a lot of members in Asia where the workforce issues are even dire. And I think for us to have an offer to upskill the workforce there is critical too. And I think that's another thing that we're working on. So we're developing certificate courses from the college. This coming year, hopefully we'll have at least a couple, one on academic skills, and I'll be talking about that at the very end. But another one on public mental health, quite rightly so, given what I talked about health inequalities. So I'm not sure what we'll call it ultimately. It depends on what the first answer to the first question is, as to what do we agree on the common vocabulary term, of course. So quite a few things happening in the college. I think just in terms of highlighting and reminding you all about the International Congress, it's going to be a live event again. It's going to be an in-person event in Liverpool, 10th to 13th of July. So I'm glad that you are here, one of the co-chairs of the conference. I'm sure you mentioned that already, but a warm welcome to everyone. Please do come. But we're still running our free webinars that we started in COVID time. And I think they've attracted a huge number of delegates who, and they continue to do so. So workforce, now when I speak to employers, this is their number one concern. And when I say employers, this is not just in the UK, across the world. Across the world, look at the issue, I think. So we have 10 million short of the overall workforce, 1 million short of mental health workforce. And I see college as being a part of that solution. I think we have a huge amount of credibility, both in the UK and across the world. I think we, and certainly as educators, I think we need to be part of that solution. So what are the solutions that we can provide? I think we know that there are many other challenges, particularly in the UK. This year, I think 65% of foundation trainees will not progress to core training. They will take an F3 year. FTEs are reducing. So we know that there is an increase in the number of choose psychiatry has been very successful. We are now actually seeing very high competition ratios to enter into psychiatry. So 100% fill rates. But if we look at whole-time equivalents, that's perhaps not such a good figure, because we know that more and more people are opting for less than full-time training. More and more people are not working full-time even after they become consultants or become GPs or whatever. I think, so that is also a growing trend that we're seeing in the medical and allied healthcare workforce. UK's reliance on international healthcare workforce has increased. So you all must have seen the figures in the last 3 years now. There are more international graduates joining the GMC register than there are UK graduates. And our international workforce has doubled in the past 5 years. This year, core trainees, 5 years ago, it was 17% of core trainees were international. This year, it's 38%. So you can see the trend. And if we don't support, we save about £250,000 by importing a doctor. And yet, National Health Service is the largest healthcare employer in the world. It's one of the largest employers, period, after the Chinese and Indian armies. And yet we don't invest £200 in providing a relocation package to all the workforce that we import. And that's a scandal. And I know educators may not necessarily see that as their role. How can we not see it as our role, right? How can we say that, well, we'll import a trainee, drop them into NHS service and expect them to work at full capacity as if they would move from Birmingham or Bradford into London? It's not feasible. And yet I think we've allowed that to happen on our watch. It's something that we need to challenge. There's pressure on educator capacity, and I think we need to recognize that. And which is why I've been working with employers to say, well, we need to really safeguard the education space in the clinical space. And that's absolutely critical. And then the workforce and well-being, morale at clinical stage. And I think retention is a big issue. I think because if we are looking for quick fixes, you can't train a psychiatrist overnight. It takes, we have to start work 15 years ago. And we've seen that government after government, and we've seen lots of them come over the last few months and few weeks. And I think, sadly, none of them are really willing to be committed to a 15-year workforce plan. Now, luckily, this government has finally agreed to have that strategy next year. We might see a change of government by then, God knows. But I think we all need to be focused on retention, because that is probably one of the quicker fixes that we can actually devise. So what are we doing as a college? We've got a run-through program in ID that was quite successful. We filled it fully. We had 9 new posts. Last year, we had 140 new posts. Got XXX because the number is almost double. It's still embargoed, so I'm not going to release the figures, but it's good. And we've done quite well despite the severe resource crunch. So the spending review has meant that health budgets across the board have been cut. But I think we, as a Royal College of Psychiatrists, have lobbied hard, and I think we've done pretty okay. But as I've said, I don't think that we can rely on recruitment alone. I think we need to kind of make sure, especially that as these new trainees come in, that we look after them and really safeguard their journey across their career path. If sort of credential has started, Helen, I'm sure you'll get an opportunity to kind of share that more widely, but that's been really successful. Our MTS scheme is growing strength to strength, which is the Medical Trainees Initiative Scheme. I won't dwell into that, but Psychiatry Foundation Fellowships, again, are doing quite well. And Ellen Wilkinson, who's our Associate Registrar for Workforce, is working on a retention strategy. And I didn't want to talk a lot about the exams, but just briefly touching upon a couple of things. Differential attainment is one of the work streams. And as a college, we have been leaders in this area. So we piloted the masterclass with HE first, and then now with GMC support. And we've seen stunning results. We've seen pass rates move from 39% to 72% using CAS Masterclass. The work I was commissioned to by the GMC to work with educators, and I think some of you may have been a part of those masterclasses. Again, the results were quite astonishing. We saw an improvement in educators' understanding of what differential attainment was, understanding of what issues affecting IMGs was, but it also changed their behavior 1 year later when the external evaluators went and spoke to them. So I think there are evidence-based solutions available for a lot of the problems that we talked about, a lot of the challenges that we talked about. And I think it really is about having the headspace and the actual time in your job plans to implement them. And I think that's something we should be talking about. Obviously, it should not all be very serious. And some of you, well, I don't know if the contestants from London team here. I do believe that, education is best when it is fun. And I think we do need to probably think about how do we make our work and our learning more fun. And so one of the first things I've done as Dean is to introduce this MindMaster quiz, which has been quite successful, I have to say. We had the finals last month, at the end of the month, the 28th November. London sadly got thrashed badly, if I may say so. But Northern Ireland were very worthy winners. Digital ready workforce. I think this is an important thing. I think it kind of, you touched upon this, Stefan, when you talked about big data, etc. But just look at some key statistics. I think so. 2/3 of our teens, half of adults use mental health apps. And I feel that a lot of our clinicians, I think we don't know enough about mental health apps. Our patients know more than us. I think that's not okay. I don't think. I think we need to know the evidence around which apps work, which don't. I think we need to kind of become a bit more literate in this area. Look at where the digital tech is going. Last year alone, digital tech in mental health has been 6 billion, that's 5 billion pounds and over. So that whole area is going to transform. And AI, machine learning is really making rapid advances. And we are not producing the workforce that is digitally literate. I don't see any fellowships in digital health and digital mental health and AI. And I think as a college, that is going to be one of my key areas where I'm going to be focusing on. I think it would be reckless for us to ignore this area, really. I think clearly, when we think of digital, sometimes we just think narrowly in terms of the post-COVID world and the fact that we are operating hybrid conferences and the fact that we are seeing our patients across video. That is one element, but there's much more to it than that. And I think, I won't go through each of those bullet points, but you can see that there are so many different areas, from remote assessments and consultations to actually digital therapies, online support, automated bot-operated tools, triaging tools, monitoring equipment, kind of understanding more about digital support for clinical decision-making, what can be nudges to us in terms of helping us with our education training, et cetera, et cetera. So what are we doing in this space? So, I've created digital literacy task and finish group. It's been co-chaired by Asif Bachlani, self-styled digital ninja, and Ross Runciman. And we should be seeing that report early next year. I think that will be quite an important piece of work. And so I do urge you to have a look at it when it is released. And again, we need to kind of translate that into action and think about what does it mean for our educational offer, not just our courses, but also in terms of our journal clubs and particularly data literacy. I think, we all have access to, as every trust, and here all of you would be part of that. We're uploading 25,000 pieces of data to NHS Digital, NHS Benchmarking, CQC, to your own trust internal mechanism. What are you getting back that actually supports your work as a clinician? And if you're not, then we should be asking for that, right? We want help to actually say, well, how is the data helping me deliver the care to my patients? How do I know that in my catchment area of 300, who are the people who have treatment-resistant schizophrenia? And that's something that the system should tell you, right? So you can check whether you've prescribed them, offered them clozapine or not. The system doesn't tell you that. I think we should be asking that, demanding that of the system. Well, why is my system not telling me that? Why is my system not telling me which are the patients who are on citalopram high dose or who are on valproate? Just, all of those things your system should be telling you. I think that's what we should be demanding of our CCIOs, our medical directors. And so creating those digital fellowships is absolutely critical. And I hope that we will be seeing that happening. And academic skills. And I think, a lot of the times, academia, I've heard this phrase, ivory tower, millions of times. And I can understand why that is the case. Because we know that there is a 15 to 20-year gap between translating academic evidence to clinical practice. And Stefan, again, you touched upon that. And that is a real bugbear of mine. How can we allow that to happen? And that certainly is the medical educator workspace, right? Translating that. Well, it's the academic space as well. It is to be owned by, but then we are academics. And I think we need to recognize that as medical educators. And I know Helen, I don't know that you know her, but a very dear colleague of mine, she works in Sheffield. And she said that she sits on the academic faculty, but she said that she felt like an imposter. She didn't see herself as an academic because unless you are, and I happen to be a medical educator academic, I'm not a pure researcher academic. I'm somebody who switched from that. I did molecular genetics as a trainee, 2 years in Nick Craddock, but then realized that my vocation was actually in medical education. And I switched. But I think that, we have to see ourselves as being in that space, as being translators of academic evidence, as being responsible for creating that skill. And I think there is a real feeling when I speak to my colleagues in cardiology and ophthalmology, where the whole idea of academic discussion is kind of very much embedded in their routine clinical activity. It happens on ward rounds, it happens in your outpatient clinic. And there's a feeling that somehow we've lost it in psychiatry. And I think we really need to reclaim that. And that is shown by the very small number of psychiatry trainees who actually do go into academic practice. And I'm saying that doesn't mean that you have to do a PhD in molecular genetics. It could be AI, mental health. It could be working with voluntary sector, it could be community engagement. We haven't explored all those opportunities. I think we need to be doing that. But look at the out-of-program research experiences. 90% of them happen in London. And that again is not okay. I think, there is a lot of geographical and rural need out there, coastal rural need. And I think we're not really bridging that. So I feel that we need to fix those issues. And I think that is one of my key priorities. Sorry, trying to stop. Then I can do here. Let me see if this works. No. Okay. Well, I mean, essentially, I was going to talk about what we are doing. I think one of the things I've launched is Dean's Grand Rounds. How many of you? I don't know how many of you have seen those. We had a couple. The registrations were really immense. Again, if you just Google Dean's RCSI Dean's Grand Rounds, you'll see them. The model is quite straightforward. It's really looking at an area where there is a gap between evidence and clinical practice, and they do abound. I can tell you that. I've asked every faculty. It's meant to be a co-hosting between a faculty and a division. And I'll explain to you in a minute why. But the faculty come up with a clinical gap. And so the first one was the addictions faculty. And the gap that they saw was that people admitted with alcohol intoxication onto psychiatric inpatient units for whatever reason were not having a good experience of withdrawal. Now, essentially what was happening was that we as psychiatrists on our inpatient units were failing to screen patients for alcohol intoxication. And then so people were not having good withdrawal. Now, I, as a liaison psychiatrist, think of that as my role to work with all the medical units where this happens. Sadly, this is happening in psychiatric inpatient units as well. And so we worked with that. It was a joint co-hosted by West Midlands Division. There are 4 key elements. The first is a narrative, a real person story, a lived experience story. So a person who had a very shabby experience of alcohol withdrawal on an inpatient unit in the West Midlands spoke about their experience. The second was the faculty's evidence from the POM audit data showing that how this was a widespread problem and not just an isolated instance, and how the national audit data showed that. And the third thing was a public health impact, where we saw a West Midlands public health consultant talking about the impact, not just on an individual patient, but on the wider health economy, in terms of morbidity, in terms of the overall cost and mortality as well, sadly. And then the fourth is a QI element. And as a college, we've invested in QI coaches who would then kind of support your team to actually do a QI project to start narrowing the gap. So you can see that we're putting a lot of effort in actually concrete stuff that we can start doing to make this happen. I'm going to try once more to see if my slides can move. No? Is there anyone else can help? No? Okay. Keyboard, let's try that. No, I think everything is stuck. Okay, we're frozen. Well, I think I'm kind of nearing the end of my talk, really. I think I'm not sure how much time we have, but I think there are a couple more things we're doing in terms of academic skills. I think we're hopefully launching a certificate in academic skills as well, because I appreciate that many supervisors probably don't feel confident in providing academic supervision. And I think we need to address that. We need to create that leadership among supervisors. And I think so we should be launching that early, well, not really, well, maybe early in 24 or late 23. So look out for that. All right, thank you. I think I'll stop there.
Okay, everybody. I don't know whether everybody's lining up for tea or have just left, but for those of you who have survived, welcome to the second half of this. For those people who don't know me, I'm Ania Korszun. I'm the lead for psychiatry undergraduate education. I work very closely with Helen and also with the lead from David Hinchcliffe from ELFT. And we spend all our time actually on the ground trying to deliver this, all of these ideas. And we've heard some fantastic ideas and all kinds of things that we should be doing. And I'm sure that we would all agree that they're great ideas. But the elephant in the room is how are we going to do it? And the fact that we have got limited resources. It's never been this difficult to get people to take part in our teaching program. And that's not because people are less enthusiastic. Every time I talk to consultants, the trainees, they're all very committed to delivering a good education experience for our students. But the services are stretched and it's a real problem. Interestingly, it's interesting to see that there's a similar sort of situation in Utrecht and the same kind of challenges. But I was recently in Japan,
And talking to Japanese colleagues there was quite an eye-opener, because the Japanese government invested a very large sum of money straight away when the COVID epidemic started into medical, into healthcare and into medical education. And so my Japanese colleagues were saying to me that they thought for them it had been a good thing, and because it had accelerated a lot of the things they wanted to do. So they were doing more simulation, they had a lot of different, they had funding for more people to work. And I don't think we're going to get that. So the next thing is to find out what happens to the meager money that we do get. I mean, we don't actually know exactly how much it is. And something that has interested Aileen and myself was to first look at this. And so I'm really pleased to welcome our friends from George's, Aileen, David, Jono, to tell us some very interesting facts about what happens to the money that we have got around here. Thank you.
Thanks all, thanks Ania. So I'm Aileen O'Brien. I'm a consultant psychiatrist and the psychiatry undergraduate teaching lead at George's, and I'm head of student welfare and professionalism at George's as well. And I mean, Isibo said that trying to talk about education isn't sexy. Trying to talk about the funding of education is probably one of the least sexy subjects in the world, but I'm confident that Jono and David, no pressure guys, are going to make it interesting for you. So, yeah, even wearing a Christmas jumper. So as Ania says, she and I, as part of the undergraduate psychiatry teaching leads, we have been talking about this for a few years. You know, where does the money go? And as the undergraduate psychiatry teaching lead at George's for some years, I kind of thought I should understand this. And I realized after a while, it's a bit of a kind of emperor's new clothes. I didn't really understand it, but no one understood it, because the whole system, without wanting to sound paranoid, seems so opaque that no one really knows where the money comes, and certainly no one knows where the money goes. So Ania and I, a few years ago, well, no, it was last year, wasn't it, actually, wrote an article in the Bulletin about this, trying to work out this opaque and almost impossible to understand system. And I think our summary was, you know, everyone has to, especially in straitened times, try and work out where the money is coming from, where it goes, and if you don't account for it, you're going to lose it, because that's the way the direction of travel is going. One of the things we quoted in our article was the BMA in 2007 did freedom of information to 33 medical schools, asking them where the money, which I think many of you will know used to be called SIFT, went. And of the 33, only 10 actually bothered to respond at all. And of the ones that did, most of them just essentially admitted they didn't know where the money went. My favorite response was, this income constitutes part of the totality of the trust's income base, and therefore is embedded within the totality of the trust's expenditure. So Ania and I published this to as ever, whenever you get something published in the Bulletin, you think, oh yeah, loads of people have read that, and I think hardly anyone actually mentioned it to me at all. So I thought, I wonder if people would just flick through and went, oh, that looks interesting. But you can imagine then, to my amazement, when I get contacted by 2 of the students at St George's who said, we just read your paper and we're really interested in this, and can we come and talk to you? So once my jaw came back up from the floor to nearing my head, Johnny and David and I have met up, and I realised that this was going to be a relationship where I was going to be hanging on their coattails very quickly, which is what has happened. So I am now just going to hand over to them to talk about the amazing work they've done based on, all I can say is all I've done with Ania really is sow the seeds. So I'll hand over to you two.
Thank you very much for that very party kind introduction. So my name is David Hutchison, and
I'm Jono de Oliveira.
hi. And it's really nice to see, first of all, that it's not just medical students. If you get a group of grown-up doctors in the room, everyone also sits at the back. So that's already made me feel nice at home. This is our first time giving a talk to a large room of people. So do bear with us if we sound or look nervous. But hopefully this information is colourful and interesting, and we're gonna get you very excited, interested, and hopefully quite angry about this. So this all started, so who are we, what are we doing? So this all started, I can't say it was totally my idea, but certainly something that happened to me on placement. I was on my surgery placement. I was in some anorectal surgery. The surgeon and his trainee were quite involved in the surgery. I was sort of trying to be keen, ask questions, get involved, and was told in no uncertain terms, stand at the back and stay out of the way and don't ask me questions until the surgery is over. So I decided to do some revision on my phone because I couldn't really see anything anyway. And then got told off for doing so. And I got told the phrase, you know, this is a privilege. We don't get paid for you to be here. Oh, and that made me so mad. And so I started thinking, hang on, that can't be right. Surely someone in this department, in this hospital, is getting paid for me to be on placement. Surely that must be how the system works. And so me and Jono, my friend and my flatmate, decided to look into this a little bit further. Sorry, I've very unfortunately cropped out our other flatmate, Will, who is also very lovely but not involved in this research. So let's give you a bit of background. How are medical student placements funded? This may be new to some of you, it might not be new to others. Forgive us if we're teaching you how to suck eggs. So the medical undergraduate tariff is paid to NHS trusts by Health Education England for hospital placements or placements in secondary care. Okay, and the rate last year was £13,000 per student per year, and that's actually gone down this year to £30,000, 700. Plus MFF, which is basically the fancy way of saying if you're in London, you get more money. If you're in an area that needs more money, you get more money, supposedly. Okay, so, and then primary care placements are funded slightly differently. Recently, and this year, they've been brought slightly more into line, as you can see, so you're getting a similar amount of funding, but it's still done slightly differently based on local arrangement, and we're not really talking about primary care placements in this talk today. It's largely secondary care. So HEE, or Health Education England, therefore referred to as HEE throughout this talk, so that's who they are, states that the tariff is for the purpose of these things, not exclusively, but these are the things that they want you to be spending money on. These are things they want the trust to be spending the money on. So direct staff teaching time, teaching and student facilities, administration, infrastructure, education supervisors, pastoral and supervisory support, student and trainee accommodation, something that we don't think gets spent on very well, formal examining, health and well-being, course fees and expenses, in-course feedback and assessment, staff training and development. There is a bit in the guidance that says it's not exclusively these things. However, there's quite heavy emphasis on these things, and this is where the vast bulk of the money should be going. Okay, they also state, interestingly, I thought I'd highlight this, there are also certain things that undergraduate medical tariff cannot be used for. For example, general top slicing for overheads to cover areas such as occupational health that are not covered by the tariff. And that's what they explain this here in this long paragraph that essentially I've paraphrased as your spending should fall into the categories we've given. Because what they're saying is that the tariff covers funding for all direct costs involved in delivering education and training, including a number of areas which would likely designate as overheads. So trusts really shouldn't just be saying, oh, we're top slicing this for our overheads. They should be saying where that money is going. So previous work, Ania and Eileen did this, talked about this just now. So Eileen was mentioning this study done by the BMA. We won't talk too much more about that. They only contacted 33 trusts. Obviously, we've got quite a few more trusts than that delivering education in the UK. Most of them didn't respond. That was in 2007. Eileen and Ania wrote this article in 2019. Unfortunately, then COVID hit. and people started thinking about other things, but I think this is super, super important. I read this article and it got me so fired up to look into this more, and Jono would totally agree. So they wrote an article explaining in layman's terms how medical student placements are funded. I found it super informative and useful. I massively recommend you read it. It's really, really good in the BJ site. In particular, this phrase, in the coming year, HE will be formally gathering information from trusts on how money is being spent, and many trusts are likely to be unprepared. Okay, interesting foreshadowing, okay, for the rest of the talk. Newer than that, and following on from what I just said, Health Education England has now announced and are now requiring trusts to file annual accountability reports detailing how they spend their undergraduate hiring income. Okay, so this is the idea that based on those categories that they've given you to spend, based on the categories they've given trusts to spend, trusts then have to say how much money is being spent in each of those categories. Okay, so these were first collected in 2021. 2021. They're currently collecting the second set. They haven't finished yet. Apparently it takes a long time because many reasons I won't get into now. They're not currently publicly available. However, we might have got a way around that. And it's unclear as to how these reports are being used at the moment. Again, more on that later. So initially, before we accessed those accountability reports, we actually just sent an FOI request to every trust in England, which is a very small project. So just asking how much funding they were getting from HE, how much they were ring fencing specifically for medical student education, how many students they were hosting, and also a couple of other quick questions. We obviously did not cover the entire breadth of their undergraduate spend, but we were asking them some key figures. So how much they're spending on teaching staff, were the teaching staff they were spending it on having protected teaching time, how much they're spending on admin staff, and was there any other notable expenditure not covered by our questions, i.e. please detail the rest of your budget if you can. We kept it simple to try and encourage responses. I understand that's a massively oversimple breakdown of trust expenditure. So John is just going to talk us through some of the early findings from that initial research, okay?
Exactly. So we sent these freedom of information requests out. And what we got back was, we thought, quite intriguing, a little bit scandalous, and should interest everybody in this room. So most trusts did respond to us after some took a bit of nudging. And most of those trusts did take students. In total, the trusts who responded to us received £489 million of funding from Health Education England, which is obviously a huge amount of money. So, as David said, we asked trusts if they ring fence money specifically to spend on medical undergraduate education. And we found that only 70% of trusts said that they ring fenced at least some of their money. So that's 30% of trusts, which are basically saying none of this money is necessarily being spent on medical undergraduates. And the total amount of money ring fence was 343 million. So that's a lot of money, but it's not anywhere near the total. And some openly admitted that they ring fenced absolutely nothing at all. As you can see quite clearly on this graph, most trusts claiming that they ring fenced all or almost all of their money, but a not insignificant number of trusts just admitting they don't protect any money to be spent on students. It could be spent on anything. So here's a nice onion diagram to give you an idea. Okay, we know trusts receive a lot of money. We know, some trusts ring fence money, some don't. But how, it's all very well saying that you protect money to spend on undergraduate education, but can you actually account for that? Can you tell us where it's being spent more precisely? So, £480 million being received, £343 million being ring fenced. But how much could trusts actually account for? It was only £166 million of the total. That's a lot of money going who knows where in our initial findings. So this is just to show that there's a huge spread in the amount, in the proportion of their income that trusts were able to account for. Some trusts accounting for all of the money that they received, they were able to say, this is how we spent it. Some trusts accounted for more than they received, spending more. Great for them. But most trusts, unfortunately, not able to account for the majority of what they received. So more than half of the trusts responding accounted for less than a third of their income. So 70% of trusts said that they ring-fenced money to be spent on medical students, but how much of that money were they actually able to account for and say how they spent it? So on average, trusts who said that they ring-fenced, this is how accountable trusts were in general for their tariff income. So as you can see, there's a big distribution, and it's actually kind of skewed towards the lower end. So on average, trusts were only able to account for 39% of the money that they claimed was ring-fenced. So this is ring-fenced money being accounted for, and it's not very good accountability. So it's easy to say that you ring-fence the money, it's harder to prove that you actually spend it on students. So our initial findings were valuable. You know, they showed us that trusts receive a lot of money and they're not able to account for it very well. But there were some limitations in what we, in the study that we carried out. Basically, a lot of that was around the fact that, there were some accounts that hospitals had, and we were able to access some of them via Freedom of Information officers. But there was a bit of a difference in sort of how diligent those officers were in sort of accessing those accounts. So we knew there were accounts there, but there was a barrier between us and accessing those. We also, there was room for interpretation of our questions. And really what would have been ideal is for us to be able to access some kind of, to access those accounts directly rather than having to go between us and other people.
Yeah, and also our own understanding, in going through this, we've learned massively more about how this process works. I still don't think we understand everything, but I do think we understand a fair amount more than probably quite a lot of people that I meet on a day-to-day basis within the medical school and within the hospital.
Yeah.
Cool. So what next? Okay, so this is the real meat and bones of this is the new exciting stuff that we come to talk to you about. So we thought we just want to go to the horse's mouth. Okay, we want to know. We weren't quite satisfied with our Freedom of Information Press. We thought that's very varied data, not as reliable as we'd like it to be. So let's go to HEE. Let's send the Freedom of Information request to HEE and ask them to give us all of their accountability report data if they have it. So we asked for these things. We asked how much tariff funding trusts were getting. We asked for their accountability reports. We asked if the accountability reports were a condition of continued funding. We asked if trusts don't submit reports, what happens? And here is what we got. They actually did reply to us and they sent us everything. And it's so interesting. I promise. So £565.4 million of HE funding was given out in 2020-2021. Okay, it's given out to 215 trusts. Quite interestingly, when we were sending our requests out, a lot of the responses we were getting were, are you sure that we get this money? We're a mental health trust, like we're not an acute trust. I promise you, your trust probably gets some of this money wherever you are. Only 168 trusts told HE how they spend it. So only 168 submitted an accountability report. That's quite a lot of missing money. And over £1 million as the median HE funding per trust. Okay, so that's a staggering amount of money, £565 million. So I just thought I'd put this into some kind of context. So this was a simulation centre that was put into place in Scotland. Just to confuse matters, all of our findings are related to England, but let's just look over that for now. So this cost £200,000. We thought we'd throw in the cost of a Band 5 manager for the centre as well. So roughly that money would pay for not 1, not 2, not 8, not 32, but 2,458 simulation centres, 11 per trust per year, okay, with money to spare. It's a huge amount, it's like an impossible amount of money to get your head around, okay? And it could be spent in so many incredible ways. Is it getting spent in those ways? Let's find out. So these are the largest funding packets handed out. So you might see some familiar names on this list, and ones you expect, and ones you might not. So Manchester getting quite a lot. Barts, hello, getting quite a lot here. George's, our home town, getting the third highest amount of money. I almost choked when I read that. Quite a few names you might expect on this list. We'll come back to that later. Also, quite a few trusts are getting very small amounts of money. This is just here for interest more than anything. But you know, Royal Marsden, I wonder what they're spending that £4,000 on. I hope they're okay. How accountable were NHS trusts for their spending? So we've rejigged this onion chart now. So this is the total amount of money, okay, so £565 million, okay, and 82% of that was accounted for in their accountability reports, much more than we found. That's still quite a lot that's missing though. That's over £100 million that we're not being told how it is spent, where it's going. And on direct staff teaching time, that boils down to about 37% of the funding that's handed out. That might be more or less than you expect. I'll leave that up to you. So a flashback, these are the categories that I mentioned trusts should be spending money on, okay? These are also the categories the accountability reports collected data in, okay? So let's have a look at this is the money shot. So this is the pie chart of how the money is spent. So direct staff teaching time, the biggest chunk by far, 38.5%. Second biggest chunk, unaccounted for money, okay? £103 million, just in a black hole somewhere, who knows where that is. Other spending, also a massive chunk, interesting considering the requirements of the funding say don't spend too much on stuff that isn't these things. Infrastructure also quite big, as you might expect. Other categories in here, sorry, these are really small, apologies if you're sitting in the back, but you will have access to these slides later. But other things like student accommodation and smaller wedges, administration, student teaching and student facilities. Great, I just thought I'd chunk out that wedge because I think that's absolutely appalling. And we all need to be really angry about that. £103 million is missing. I quite like some of that. Okay, I just thought I'd pull out some things here. So like I said, £103 million accountable. However, the true figure is actually likely to be a lot higher than this because some trusts reported overspends, okay? So they're making up for other trusts that are under accounting for their money. And so actually ruling out overspending, the true figure is more likely to be around £122 million that's missing, okay? And is all of the money going where trusts say it is? Can we actually believe any of this? Privately, we've had a couple of doctors saying to us that they remember filling out these reports and thinking that the whole thing was a bit fudged. So I'm not super relying on a lot of this as gospel. However, it is the most concrete evidence we've got yet as to where this money is going. So how accountable are trusts? As you can see, quite a lot of trusts are just not accounting for anything. So 0% of their funds accounted for. So most of those are trusts that have not submitted accountability reports. In fact, almost all of them. Quite a lot of trusts accounted for more than 100%, so overspending. So they're making up for some of the others. Quite a few accounting for most of it, but as you can see, quite a few in the middle accounting for between 31 and 90% of their funding. Okay, so not all of it. So where is that money going? This is just stuff that I think I've basically already said. Quite a lot of trusts basically just not fair. So the average funding accounted for per trust was about 76% if you exclude overspenders. Okay, so interesting that about a quarter of that money per trust is missing. Just a case study out of interest. This might have already come up, but let's see if we can guess the trust. Okay, so they got about 14 million. Second highest sum awarded to any trust. 50% of the money received, not accounted for. 18% of the funding was spent on direct staff teaching time compared to an average trust share of 29%. Any guesses? Barts Health. Yes, it's Barts Health. Oh, we'd love to have put George's up here. Sadly, Barts Health was actually a bit worse. But congrats to Barts Health for actually submitting an accountability report because quite a lot of trusts didn't. Okay, and that's what we're going to move on to now. Okay, so that's the caption of that title. Okay. So these are our top 10 trusts that John has talked about, the most funds unaccounted for.
Yeah, this is our unaccounted for leaderboard. As you can see at the top there, we've got Oxford accounting for none of their £12 million. They're also the trust that receives the 8th largest amount of money. You've got Royal Free coming in second. Barts is there on in fifth place. They do account for 50% of their total, as we saw, but they receive so much money that it's still £7.2 million of unaccounted money. Yeah, £61.9 million missing on this list alone. And okay. So we're going to break down that pie chart that David showed us earlier and look at the different categories. And one of the main things we see is that there's a huge spread of spending. So some trusts spend a huge proportion of their income in one particular area, others spend almost nothing. Look, so this is direct staff teaching time, the meat and bones of medical education on placement. As you can see, you know, a few trusts spending nothing on that, some spending all of their money on that, and there's a huge spread in between, absolutely huge. 38.5% of the total income, you know, total spending was on direct staff teaching time. Okay, but so the thing with this is, even within the kind of better figures that we received from Health Education England, there's still a bit of room for interpretation on the part of trusts. So what one trust, so two trusts might spend money on exactly the same things, but one classifies all of that as direct staff teaching time, and the other one classifies some of it as direct teaching, some of it as educational supervisors, for example. So we thought, well, maybe we'd see a bit less of a spread in priorities if we created a composite value where we took into account so we added together all of those different sort of main categories that relate to the teaching experience that students have directly when they're on placement. So we added together direct teaching time, education supervisors, teaching and student facilities, course fees, in-course feedback, staff training, and we thought, well, maybe we'll see less of a spread because of that room for interpretation. There was a bit less of a spread, but as you can see, so there's still a huge range in the amount of spending on these on just direct educational experience that students receive on placement. Some spending 100% of their money. Still, you got one or two trusts spending nothing on any of these. And what's that all about? So just have a look at a couple of the other categories. There's less spread where it comes to spending on infrastructure, but still, a bit of variety there. Some trust spending nothing at all, others spending sort of 30, 40, 50, 70%. And overall infrastructure spend, just out of interest, was 9.8% of total spending. So how much did trust spend on admin? It was mainly, most trusts spent between 1 and 10% of their total expenditure on administration. So 4.7% was the total sort of admin spend of the total spending. Okay, and then there's this other category that David mentioned earlier. What's that all about? What was in that other category? So just to have a quick flashback to a slide David showed you earlier again. So this money that trusts receive cannot be spent on general top splicing for overheads. As a general rule, it really should be spent on these specific categories. Don't just generally spend the money on overheads. As you can see, £13.5 million of the money in the other category was spent on overheads. 10.5 million was probably spent on overheads, but it was a bit vague. There were little notes attached to the spending that trusts put in the other category. We thought these were probably on overhead, but it's a bit unclear. 10.9 million pounds of the money that trust put in the other category was just not explained. So actually our accountability statistics, they're sort of a little bit higher than they should be, because there were some trusts that put money down but didn't explain it, so it wasn't really accounted for. There's just money on the sheet. 6.4 million of just sort of other miscellaneous things. And then £50 million on time lost to teaching, which is an intriguing category that we'll come back to in a minute. So just general look at the other spending again. So on average, only 68% of the other spending figures were explained in any way. The others were just, as we said, numbers on a sheet of paper, and we have no idea what they mean. So this time lost to teaching, what does it actually mean? Does it mean anything? We're not completely sure. So essentially, we think we're talking here about when you're a medical student on placement and you're shadowing a doctor, and a proportion of their time is spent not on seeing patients but on teaching you, and this is time lost to teaching.
But there's cost of staff teaching while delivering patient care is, I think, how Department of Health have explained it.
Yeah, exactly. But there's a bit of ambiguity here. For example, some trusts have put this in the other category as time lost to teaching or cost of staff teaching while delivering patient care. But also this might well be how some trusts are figuring out their direct staff teaching time. You know, so again, there's a bit of room for interpretation in the figures. And to give you an idea of what the Department of Health say, you know, is given as an example of how to calculate this figure. They say, you know, if, for example, a consultant combines teaching with patient care and the students with them for 30% of their time, and the consultant spends 50% of that time doing direct teaching, then the consultant is spending 15% of their total time providing teaching whilst delivering patient care. And then 15% of the total cost would count as cost of staff teaching while delivering patient care. There's a big if there. This is very, you know, we're making a lot of assumptions here. And
this has become a little bit of a running joke between us.
yeah, it's a message I
It's a text I got from Jono
yesterday morning. And I mean, a lot of students have this experience. I mean, my current placement, I met my supervisor just before his clinic. He said to me, "Lovely to meet you, Jonathan. I'll see you at the end of the placement for your sign-off." That's just how it goes sometimes. So there are a lot of assumptions going into these calculations. Do you want to precise that?
Okay, so that was our findings from HEE, and thanks for bearing this because I know there's a lot of chunky graphs, but hopefully we've managed to sink in some really quite shocking things. We thought we'd go back to our freedom of information initial request to all of our trusts, because we've got some really interesting responses that we think help us elaborate on some of these weird and wacky figures that HEE are getting. So Devon and Exeter, who get 4.6 million, said the trust does not currently separate costs for the undergraduate medical tariff and therefore unable to provide a response. Okay, Oxford University wouldn't tell us how much money they got and said the information in general is just not held, so they can't give it to us. So we're already getting a bit of a picture that a lot of these trusts, the information is not at their fingertips. Okay, they're looking around to try and find it and they're just giving up. Okay, East Lancashire, the information is commercial in confidence and they didn't want to give it to us.
But prejudice their commercial interests.
The Dudley Group, this would be an oppressive burden on the authority and its services, and that's why they turned us down. Another key category of responses that we got, so Shrewsbury was mentioned this contribution to overheads and infrastructure costs, which I thought was a very interesting way of phrasing it. I'm not sure what overheads are if they're not infrastructure. All of the funding received was spent specifically on the education of medical education undergraduates in the most recent financial year, including contribution to overheads, as you can see from Hull. Overheads quite a common theme here. Sheffield, very interesting, very high up on the list of unaccounted for funding. Undergraduate funding contributes to the functional pay and non-pay budgets throughout the trust. Intriguing. Only specific funding relating to posts which work purely for undergraduate medical education. That's our timer saying we should shut up, but I'm going to quickly just finish up. Plymouth said the trust does not hold separate budgets specifically for the costs related to medical education. Costs are incurred across a wide range of clinical and non-clinical areas responsible for the delivering of undergraduate medical teaching and associated administration. There's a bit of a theme here, okay, from a lot of these places, and the theme that none of the trusts are saying, but we are thinking, and we can't prove this, and we haven't proved this in our research, but essentially what is happening in some of these trusts is the trusts are saying, thanks for the money, we'll have that and we'll give it wherever we want, and it will probably be absorbed into our budgets and we probably won't actually send it where it needs to go. We haven't found proof for that, so sorry if I'm just libeling.
There's a bit of proof.
There is a little bit of proof towards that. So just to wrap up, Southampton told us, and this is really key as well, because this is a key thing that's come up again and again. I think it's already come up today about job planning, okay, and protected teaching time in job planning. So Southampton told us this time is not identified separately from SPA and job plans unless the staff have a leadership role. Sounds crazy. You've identified a problem and you're not doing anything about it. Same with the Royal Free. Royal Free articulated this so well. I thought, excellent, you've really identified a really good teaching point for yourselves here. Delivery of education involves a wide range of costs, many of which are hidden costs, embedded within the cost base of service lines, blah, 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 and much of which is not accurately reflected in job plans. Hooray! They can go away and do a lovely meeting about that and work out how to put that accurately in the job plans. Because that's not really fit for purpose, is it? So, how do we change this? Okay, we've come up with some problems that we've identified. So problems we've identified with this research, okay? So a lack of accountability. There's also little proof. So trusts can basically say what they like in these accountability reports, okay? And they don't have to provide any accounting to HEE to prove this. So I'd love to take all of these trusts on at their word. I've seen enough to be a little bit suspicious, okay? There's no minimum requirements on spending. So for example, direct staff teaching time, some of these trusts are getting grants and spending 0% of that on direct staff teaching time, I would say as a medical student, that's a bit whack. There's also no limits on the amount that trusts can spend on certain categories of things, i.e. overheads or infrastructure. That also seems very strange. What else is going on that's wrong, Johnny?
Well, there are no consequences for trusts failing to account for their money. Oxford can account for none of their money and still carry on receiving it year after year. The funding system is also, as we've said, multiple times, incredibly complicated. It's difficult to understand for anyone who doesn't kind of have a special interest in it and time to invest into it. And as we've said, job plans are often not fit for purpose. And don't allow for the accurate recording of tariff spending and for money to go to people who are, making a special effort to deliver education.
Yeah. So what can we do about this? So we come up with a few proposals, not necessarily for you guys, for the whole system, but I really, really hope one of these things that we can do from this talk today is get you guys talking about this, hopefully get you guys interested, hopefully even get you a little bit angry about it. You can join our cause and we can really, really campaign for some good change on this locally and nationally. So what we'd like is some enforced accountability, actually. So at the moment, there's no consequences. HE admitted that to us for failing to return an accountability report. What's the point in doing it then? Why are the trusts who are doing it if there's no consequences for not doing it? So we'd like to enforce that. As a suggestion, financial penalties payable to the universities, which then they can put into their medicine courses. That would be lovely. There's something that we at least get out of that. A minimum spend on staff teaching, I think that's a really sensible idea. I think as medical students, the one thing that most medical students would say we want more of is direct staff teaching time. And I would love there to be a minimum proportion of spend of the tariff received on that. And a limit on overheads and top slicing. These are two words that came up a lot in our other expenditure, and I suspect it's going on elsewhere and being covered up a little bit better. So a strict limit on the percentage of the money that this can happen to. We also just want more clarity for trusts in what they can and can't spend the money on. It's all a very nebulous system at the moment, and there's a lot of room for interpretation in the HE guidelines. And we also want transparency with medical students. None of my friends know how this works. Okay, none of my friends know how trusts get their money, how consultants are sort of paid in their job plans for medical student education. No, none of my friends know this. I didn't know this until about a year ago. I suspect some of you didn't know this either. And so particularly for medical students, actually, I think it's really important to know, for example, if it is true that trusts are paying 15% of their consultants' wages for 15% of their time for medical students, I'd quite like to know that, because I can tell you I've never had it. On any of my placements, I've never had 15% of my consultants' time. I've had fantastic consultants, don't get me wrong, some, but I've never had that much time. I've never had that much time. John, just finish up for us, please.
Yeah, exactly. We want to educate students and doctors about how the system works. We don't want to have we want there to be no future scenarios where a surgeon can tell a student, we don't get any money to have you here. We think it would make a difference to the culture, when you're on placement, if people were a bit more aware of the fact that they're actually getting solid money for having you there. And we also, we want educational departments to be able to say to their trust, you're getting money for having students here. We want to see that money. We want to be able to have some kind of control over spending it. So we want to, give more agency to people with an interest in education and providing it to students. And we want protected teaching time in job plans, as was suggested by our supervisors.
Yeah, importantly at all levels as well. Teaching is not just provided by consultants on secondary care placements. I think there's SPRs in the room. I'm sure you spend quite a lot of time teaching students, probably more time than your consultants do. Certainly that's been my experience. Certainly I've had more teaching from F1s and F2s than I have from SPRs as well. So at all levels, there's education going on. So why are all doctors at all levels not benefiting from that? So future plans, just really quickly, because we've massively gone over, so I'm so sorry about that, but just follow up. We really want to do two things. We want to get this published. This information is not currently publicly available, the information from HEE. We don't think that's right. I'd love to get a website where students and educationists alike can log on, look up their trust and find out exactly how much of their money at their trust is going where and how much of it is unaccounted for. so people can lobby locally. That's something I'd love to do. And we want to instigate real change. We've got a massive wish list for better quality medical student places. It's not all about money, but it starts with the money going to the right places. So that's why this is so important. And just wrap up with some thanks. Thank you, Eileen. Thank you, Ania. Freedom information officers that have helped us have largely been amazing, actually, and they have a very thankless job. Health Education England also answered loads of our questions, despite the fact they didn't have to by law. They were really, really helpful. Yes, that's my presentation today. And any questions?
It's really fantastic work, and we're so proud that we actually inspired you to do all of this. They're not your average students, actually. We've got, I think, Chano, you're a historian in your previous life, and you won't be surprised to know that David was a news reporter. So, you know, they were sort of our secret weapons to get some of this information. Now, do we have anybody from the Trust who might want to make a comment or ask a question? Go ahead.
I think from the other, we're working in the system with real structures. There's a lot of lack of element. So you can see sort of the balance, you know, between of this hardship, trying to keep teaching and keep that opportunity. So that there's something, there's also this hierarchy must help.
Yeah. I'll just respond to that by saying I totally get your point, and this is one of the main points that we've heard from people, is that there are fixed pots of money, okay, and we know this, and we know there's fixed resources. However, if the cardiology department's fixed pot of money also includes part of the neurology department's budget that should be going to the neurology department, should the neurology department just go, oh well, the cardiology patients need it? No, that shouldn't really be happening. Money for education should, in my view, be going to education, and the fact that money might be going elsewhere and being spent on worthwhile things possibly elsewhere in the trust is, to me, irrelevant, and it should be going to education.
And on another level, I mean, the GMC tells us we need to, you know, practice probity as doctors. It needs to be all about the truth and transparency. And we've heard concerns from people about revealing these truths because this money's been used to prop up services elsewhere. But I think we can't have that double standard. We need to start with the truth and transparency and build a better system.
Can I just add something there, that I was trying to find something out in the opposite direction, which was how HE decide how much money they should be giving to a particular trust. And so that what happens is that whatever they're delivering is reported to the medical school, and the medical school then report that to HE. And we thought, yeah, that's good, you know, so we can work out how the money's organized. But it's actually, they use a secret formula that they don't divulge. So at HE level, there's some sort of secret thing going on. And one other thing I should mention is that, you know, you've shown what Barts Trust is up to, but we're actually the East London Foundation Trust.
Yeah.
And I have to say that we're very generously supported. We have fellows in medical education that are paid for by the trust, and we wouldn't be able to deliver the course without them. And the associate dean is supported. So, you know, there are trusts who are actually delivering, but I think we don't have much transparency at all.
Couple of questions down here.
I think this is absolutely fantastic and speaking about it. But I think one of a really important point is that if you are propping up your services with this money, then it means that we don't really know how much the services cost to run. That's the big thing. It means then that the money that's going to be given to keep that service going is going to be less than less each year if money is being used. That's the problem.
Absolutely, and that's another angle to approach the problem from. And if I didn't have my finals and my SJT this year, I would certainly be looking at that as well. But yes, you're very right. Yeah.
Sabah.
I wrote an article 10 years ago, highlighting the ways of search technology. And my trust, I'm not sure whether it's good or thinking of that, we should have foundation trust whether they're internal, but we have ring-fence funding. I think the issue is with lack of medical education, not having the financial literacy to read spreadsheets. I didn't have the ability to do that. I had to learn it. I think when you do have ring-fence funding, that the actual funding follows the formula. There's student week amount that you get. Yeah, most trusts do have a top slicing, 15%. And you can work out what exactly is due and how much is your salaries and what money you have left over. Which is why we do lots of things in Derby, which others haven't been doing. We can pay 50 patients to get involved in medical education, develop all our simulations, etc. Nearby interest haven't been able to because they haven't got that.
Yeah, I totally agree. And I think it's crazy that as doctors, we're expected to go on and become leaders and managers, and we don't get training to do this and read spreadsheets and work out formulas and things like that. And we have certainly learned a lot doing this. My Excel skills are now great. So if you want any help, I'm happy to lend you a hand.
That's really excellent work. Thank you very much.
Thank you. Thanks for your time.
We're going to finish off with another, we've been talking about all of the teaching that's delivered within the course, but extracurricular stuff also needs to be supported. And we've got a fantastic psychiatry student society, and Lucy is our president. And also we have our fellows here in medical education who deliver a lot of the teaching. So I'm going to hand over to them for the last section.
So hi everyone, I'm Lucy. I'm a fourth year at Barts and I'm the SNEXOC president this year. I'm just going to talk for a few minutes about what we've been up to so far and how you might be able to help us in the new year. So post-COVID, we have had quite a struggle getting people to turn up in person to our events. So we've really tried to collaborate with different societies across Barts and beyond Barts to try and get more people interested in psychiatry. So we started off the year with a meet and greet. We had people from different subspecialties come to talk to us. We've collaborated with Derm Society to run a talk on the kind of common conditions they see in psychoderm clinics. A couple of weeks ago, we ran MedFest. So this year, the theme was connection, and we showed some short films and had what I think was a really insightful discussion with the panel and our audience. We have collaborated with Malta PsychSoc to run this Living With series. So this is where students with experience of mental illness come to talk to us, and we've run one on bipolar disorder, and we actually have our talk on depression tomorrow. This is a bit of a kind of tenuous link, but we collaborated with the Barts Cycling Society to raise money all year round for the listening place. So in the new year, we're going to have an event where people of all abilities can join a stationary bike ride or a Boris bike ride around London. And then the cycling committee will continue to run this for the rest of the year to kind of raise awareness. And finally, we've collaborated with King's PsychSoc, who have this existing program set up called Psych for Sixth, where they go into sixth forms and talk to people about psychiatry, kind of get them interested in it before they even come to med school. But we're trying to extend this to East London, so Tower Hamlets and Hackney, and we're just kind of going through the safeguarding stuff to do with that now. So looking forward, we have a mentorship scheme that's been really successful in previous years, and we would really, really appreciate it if anyone in this room would like to sign up. The QR code is here. Basically, this would involve meeting with a student kind of once a month, more if you're interested. It really depends on you and the student. Previous years have done some shadowing or some just kind of career chat, that sort of thing. If you're interested in teaching, I know people are going to speak more about this after, but we would love for you to come and do some teaching as well. And then in the new year, our talks, we were hoping would focus on kind of the awareness weeks that coincide year. So for example, in March, there's Eating Disorders Awareness Week, and there's World Bipolar Day. So if you're interested in anything really, please get in touch with us, because we'd love to have a talk from you. Yeah, our email's here and that's our Twitter as well. Yeah, that's it from me. Thank you.
Yeah, sure. Thank you so much, Lucy. That's really interesting. Oh, perfect. Thank you. So we're aware that it's very near the end of the day, so we will be very, very speedy. We just want to very briefly introduce ourselves and to try and raise the flag of medical education. Hopefully you've been really inspired by all the amazing talks we've heard today. So I'm Michaela, I'm one of the clinical fellows in ELFT.
I'm Anne, I'm one of the clinical fellows in ELFT.
So we're where part of the money goes, but not necessarily all of it, but who knows. So how can you get involved in medical education in ELFT now? We've got lecture programs, we've got clinical skills or clinical placement activities, depending on which trust you're in, they're called different things. And we also have the actual course clinical placements themselves as well. So very briefly on the lecture program, for the year 4 group, they have just, this might be very obvious to some people, but just in case you're not aware, they've got a 6-week psychiatry module that happens 6 times in the year. They've got 1 week of introductory lectures and then sort of 5 weeks of placement after that. And we have lectures every Monday. So there's plenty of lectures and lecture opportunities for people to be able to help us contribute to within that programme. I've said, and it's all face-to-face at the minute, which is really nice. You get to properly engage with students and it's just so much better than doing it all on video. We've got support with interactive platforms, we've got Mentimeter, and there's lots of those lovely sort of presentation sets that you can get, exactly as I think John found as well. You can get lots of really beautiful ways to make presentations, and we can help support with all of that as well. Thinking about our year 2 group very briefly, so we've got medicine in society. This is virtual because it's to a group of 250 students at a time, so it's not quite possible to do face-to-face. We've got 6 different themed days and we've done a few different days with them so far. Again, it's been really interesting. It's a really nice opportunity to get in early into the curriculum and to get psychiatry as a message in really nice and early. So we've done general adult, stigma, trauma-informed care with them. We're doing health inequality session next week, as Helen touched on as well. I'll hand over to Anne to talk about the next few days.
And then early next year, we're going to be doing the Old Age Day and the Intellectual Disabilities Day. So if anybody's interested in that, please do get in touch. It's for second year medical students, so it's very much introductory. So then we move on to the clinical skills or clinical placement activities, whatever you want to call them. They're for the year 4. It's going through this OSCE style teaching. At the moment, I think both trusts are running a hybrid format, so some face-to-face, some online, which could sway sort of your availability and all of that. And generally, ELFT do it Wednesday morning and ELFT does it on the Friday afternoon. And then, oh yeah, just in general, we can do assessments of teaching for trainees or the assessment for anybody doing the SILTS program. We can offer certificates for people who are involved. And also, if any of the higher trainees have want to do a special interest in MedEd and want to discuss with us, if we don't know the answers, we know who to sort of send you to and who you can discuss that with to be involved. So student clinical placements. So usually there's 2 students at a time. They're expected to attend 3 days a week, which is Tuesday, Thursdays, and Fridays, i.e. when they don't have lectures or the student selected components. And generally the placement is for 2 to 3 weeks, sometimes 1. I mean, there's sometimes been a shift where there's been 1 week of specialized and then 2 weeks of more generalized placements, but generally not more than 3 weeks. And what we expect from the students, first of all, we don't expect everything to come from consultants anyway. We expect sort of the students to engage with the whole MDT, but overall, they need to have 5 clinical teaching experiences. So we're talking a ward round, a clinic, a home visit, 5 different, they can be the same, they can have more than 1 ward round, but there have to be 5 experiences at least in total. The students have to write 5 written cases, which needs to be signed off, i.e. that patient was really here and they really existed and this is what's happened kind of thing. So it's not like delving into a lot of detail. And then 1 observed clinical task, and the consultant at the end of the placement needs to complete the end of placement and professionalism form. So from what work you'd have to put in from a sort of signing things point of view, this is really it. And it's all done on a online platform now called PebblePad, so no books and papers and all of this. Oh good, that one's not come out well. So I will sort that. How do I go? There we go.
So what we want to be able to share with that is a QR code to have people to be able to sign up. So I can stall while Anne manages to try and find that, hopefully. So there's so many different teaching opportunities that we're able to help support you with. We know exactly, as Ben's already said, about the huge restrictions on people's time and all the different limitations on people being able to access teaching. And in terms of teaching ourselves as clinicians, often it does end up dropping down our radar a little.
Really?
I don't know if there's a way of muting it for the time being, so we don't.
No,
see
I
your
don't
emails
even
as
do
well.
it. It's not emails.
We do also, so our emails go on pretty much
There we
every
go.
email to different medical education departments as well. So if you email the NELFT medical education department, you'll be able to get in touch with Anne. If you email the ELFT team, then you'll be able to get in touch with myself or Marcus. But yeah, oh, and there we are. There's the QR code. So
Yeah, I just need to share it now on the Zoom thing.
oh, very true. So if you're interested, if you're able to scan the QR code when we manage to get it.
Yeah,
up,
let me just leave.
so please do get in touch with us, either by filling in our wonderful form now, we've managed to find the QR code, or just emailing us.
If you're not sure about what times, you can just talk to us. We can discuss what there is, even if you just tell us interest, and we can make sure that the sort of our seniors have that information, should, you know, even be sort of contacted in for the next academic year, just essentially give, you know, let us know that you're interested.
And if there's anything we can do to help you get involved in teaching as well, then just let us know. Thank you very much, everyone.
We will ask our medical departments to send the link across as well.
After that plea, how can anybody refuse, really? So it's been a really interesting afternoon. I mean, I've certainly learned a lot actually listening to this. And so it's time now to move ourselves. Is it Butcher's Hook, Helen? Where? Yeah, the pub is Butcher's Hook, isn't it? Our chosen hostelry. Is it? Butcher's Hook. So that's for those people who don't know, when you come out of Barts and you turn right and you can see the Butcher's Hook there on the right. But just follow us. So thank you very much for all of you who stayed for the afternoon. Thank you.
For all of you, for all of you online, I've put the link in the chat. I stop this. Stop. Stop it. I can end the call, right? Thank you. I can end the call, right? Can I end the call? Bye bye, people online.